Welcome, curious minds, to another deep dive. Have you ever paused to consider the silent, intricate forces constantly at work within you, keeping you alive and vibrant?
Mm.
We're diving deep today into the fascinating world of fluid and electrolyte balance in your body. It's a system so fundamental, so incredibly precise, yet, so often just taken for granted.
It truly is. Imagine your body not simply as a collection of organs, but as a dynamic, interconnected internal ocean.
An ocean, wow.
Yeah, and this isn't a static pond. It has its own complex currents, pressures, and a meticulously maintained chemical composition that has to be held with astonishing accuracy.
Right.
For us today, our mission is to truly master this information, understanding it with the depth and clarity of elite professionals. When you grasp these underlying principles, you begin to see your own health, and indeed the world around you, through an entirely new lens.
And today, we are going profoundly deep. We're cracking open some highly specialized medical texts, particularly Nurse Anesthesia 7E, to truly unpack the fundamental principles of fluid dynamics, the cutting-edge strategies that are revolutionizing patient care,
Yeah.
and those tiny but incredibly powerful players, your electrolytes, that dictate so much of your health, especially during critical moments like surgery. Our journey together will transform you from a curious observer into someone who genuinely grasps the intricate complexities of this topic.
You'll gain an appreciation for everything from how water is precisely distributed throughout your body to the latest scientific discoveries that are challenging long-held medical doctrines.
Oh, interesting.
And even why a simple salt solution is anything but simple in a clinical setting. Get ready to gain a deep understanding of what the experts understand and to truly marvel at the intricate, ceaseless balancing act your body performs every single second of every single day.
Okay, let's unpack this incredible internal ocean. So let's begin our exploration by truly understanding the scope of your body's aquatic nature. When we talk about total body water, or TBW, we're not just talking about a splash. For an average adult, water makes up roughly 60% of your lean body mass. Imagine that. Well over half of you is water.
It's a staggering amount.
Yeah, it's like carrying around a small aquarium within your very being.
It is. And what's truly remarkable is how precisely this water is organized and distributed.
Yeah.
It doesn't just slosh around.
No.
It's meticulously divided into two primary compartments. The first, and by far the largest, is the intracellular volume, or ICV.
ICV, okay.
This is the fluid inside your individual cells, and it accounts for about 2/3 of all that total body water. This is where the magic happens, where the vast majority of cellular machinery and metabolic processes take place.
Right, inside the cells. And then outside your cells, we have the remaining 1/3 of your total body water, which is the extracellular volume, or ECV.
Yeah.
But even this ECV isn't just one single pool, right? It has crucial subdivisions.
That's right. Each playing a distinct and vital role in the grand symphony of fluid balance. Within the ECV, we find the intravascular compartment,
Okay.
which is essentially your plasma volume, the liquid component of your blood.
Got it.
This makes up about 1/4 of the ECV. Then there's the much larger interstitial compartment.
Interstitial.
Yeah, which is the extravascular fluid found in the spaces between your cells and tissues. This is about 3/4 of the ECV.
Oh.
Think of it as the nutrient-rich bath in which all your cells are constantly immersed, allowing for critical exchange of substances.
Like a cushion between everything. And there are also these fascinating specialized pockets of fluid within the ECV called transcellular fluids.
Oh, yes.
These include essential fluids like cerebrospinal fluid, which cushions and nourishes your brain and spinal cord, synovial fluid, lubricating your joints, various gastrointestinal secretions, and intraocular fluid, maintaining the pressure and health of your eyes.
Crucial stuff.
Absolutely. But you said they're often considered non-functional when we talk about overall large-scale fluid dynamics. Why is that?
Well, non-functional in the sense that they are largely isolated from the major fluid shifts that impact the rest of the ECV.
Ah,
While absolutely vital for their specific functions, they're more like highly specialized enclosed reservoirs, not participating much in the big back and forth.
okay, that makes sense. So how do scientists actually measure and confirm these precise fluid volumes and their distribution? It's not just a guess, right?
Oh, definitely not. They've corroborated these volumes through sophisticated laboratory methods. This includes using things like radioactive water to track overall body water,
Ah.
isotope-tagged red blood cells to measure blood volume, and selectively permeable protein-bound radioactive tracers that allow them to precisely track fluid movement and distribution across different compartments with incredible accuracy.
Wow.
This isn't theory, it's meticulously measured science.
Now let's shrink down even further to the microscopic superstars that truly make the system hum, the electrolytes.
The tiny titans.
Exactly. Imagine a vibrant, intricate dance happening constantly, both inside and outside your cells. You mentioned the electrolyte composition inside cells, the ICV, is dramatically different from outside in the ECV.
Absolutely.
Fact.
Dramatically different. And this difference, this electrochemical gradient, is not just a detail. It's absolutely fundamental for every single cell in your body to function correctly.
Okay, so walk us through that difference. Who are the stars in each compartment?
You've hit on a core truth. In the ECV, the extracellular volume, the primary positively charged ion, or collocation, is sodium, Na+.
Sodium, right, the salty one.
Yes. And its main negatively charged partner, the primary anion, is chloride, Cl. Now, if we shift our focus inside the cell to the ICV, the roles are basically reversed.
Okay.
Inside, potassium, K+, is the primary annotation, the phosphate serving as the primary anion. These distinct concentrations are maintained not by chance, but by active, energy-intensive processes.
And the unsung hero, the tireless workhorse orchestrating this precise and vital separation, is the sodium-potassium ATPase enzyme, often just called the Na plus K plus ATPase.
The pump, yes, the absolute hero here. This incredible enzyme embedded right in your cell membranes is a master of active transport. It uses cellular energy ATP to constantly pump sodium ions out of the cell into the ECV,
Pushing sodium out.
while simultaneously bringing potassium ions into the cell. This active pumping action is fundamental to life itself. It creates the resting membrane potential critical for every nerve impulse. It enables your muscles to contract, and it's absolutely vital for maintaining the cell's very volume, preventing it from either bursting with too much water or shriveling up from dehydration.
So it keeps the balance just right. Despite these dramatic compositional differences, you said an incredible state of osmotic equilibrium is constantly maintained between the ICV and ECV. How does that work?
It's fascinating. The cell membrane, while selectively permeable to solutes like sodium and potassium, is quite permeable to water. This means water can freely move across it, shifting in response to solute concentrations. This movement ensures that cells neither swell excessively nor dehydrate, constantly seeking a perfect balance. It's a beautifully orchestrated, delicate equilibrium that underlies all cellular function.
So to keep this entire highly complex system running smoothly, a healthy adult needs a pretty consistent daily fluid intake.
Exactly. With a normal body temperature and standard metabolic function, we're talking about roughly 25 to 35 milliliters per kilogram of body weight per day.
Okay, so for most people, that's...
Roughly 2 to 3 liters. That's your baseline daily fluid requirement just to maintain this intricate total body water homeostasis. It's a testament to the body's constant demand for this essential liquid.
Moving beyond the cellular level now, the fluid exchange between those two extracellular compartments, the intravascular and interstitial spaces, that's governed by something called Starling forces.
That's right. These are essentially 4 distinct transcapillary pressures, whose gradients literally dictate the direction of fluid movement across the capillary endothelium, that delicate inner lining of your blood vessels. It's like a microscopic ballet of push and pull.
Okay, let's break down these 4 critical forces, understanding their individual roles in this fluid ballet. First up is capillary hydrostatic pressure, EC.
Think of this as the intravascular blood pressure, the direct force pushing fluid out of your blood vessel.
Okay, the push out.
It's driven by your heart's pumping action, your cardiac output, and influenced by the tone of your blood vessels. When this pressure rises, it clearly favors filtration, actively pushing fluid from the blood vessels into the surrounding interstitial tissue spaces.
Got it. So counteracting that outward push is the interstitial fluid pressure, PIF.
Exactly. This is the hydrostatic pressure within the interstitial space itself.
Yeah.
In most of your body's tissues, this pressure is actually slightly negative relative to atmospheric pressure.
Right, it's like a vacuum.
A subtle vacuum effect, yeah, possibly maintained by the gentle contraction of lymphatic vessels. However, in more rigid or encapsulated tissues, like your kidneys, brain, bone marrow, and skeletal muscles, the interstitial fluid pressure can actually be slightly positive. An increase in this PIF would, conversely, favor absorption, effectively pulling fluid back into the intravascular space.
Okay, push out, pull in. Then we shift to the osmotic forces, which are all about the pull of proteins, right? Plasma oncotic pressure.
Precisely. This is the osmotic pull exerted by large colloidal proteins, primarily albumin, located within the vascular space. A higher plasma oncotic pressure strongly favors absorption, actively drawing fluid back into the blood vessels.
And its counterpart is interstitial oncotic pressure. Yeah.
Correct. That's the osmotic force exerted by colloidal proteins that have managed to escape into the interstitial space. An increase in this pressure would, by contrast, favor filtration, pulling fluid out of the vessels and into the tissues.
And here, you mentioned we absolutely must highlight albumin's starring role. Why is albumin so critical here?
Due to its relatively smaller molecular weight and its significantly higher concentration compared to other plasma proteins, albumin is the primary determinant of both capillary and interstitial oncotic pressures. This single protein plays an absolutely critical and outsized role in maintaining precise fluid balance throughout your entire body. Without enough albumin, the whole system can falter.
The complex interplay of all these forces is elegantly summarized by the Starling equation. We don't need the exact formula, but the concept is key.
Right. The concept it captures is that net fluid movement is determined by the balance between hydrostatic pressures pushing fluid out and oncotic pressures pulling it back in, factoring in the capillary's permeability.
What's particularly fascinating about these net filtration dynamics is how they shift along the capillary.
Exactly. Generally, net filtration tends to be slightly positive at the arterial end of capillaries. This means fluid is pushed out into the tissues where it can deliver nutrients. But then it subtly shifts, becoming slightly negative at the venous end, favoring fluid absorption back into the vasculature, bringing waste products back for removal.
And overall, when we look at the balance of filtration pressures throughout the body's capillaries,
It is, on average, slightly positive. This means a small percentage of intravascular volume, about 2 milliliters per minute under normal physiological conditions, is constantly filtered out of the blood vessels and into the interstitial space.
but that fluid isn't just lost, right?
No, absolutely not. It's efficiently gathered up and returned to the intravascular space by the remarkable lymphatic system. Under normal fluid volume conditions, euvolemia, this net fluid filtration is precisely equal to the lymphatic flow, ensuring a steady, healthy state of fluid balance.
While Starling's description formed the bedrock of our understanding for over a century, you mentioned a more recent groundbreaking understanding has emerged, emphasizing the crucial importance of the endothelial glycolytics.
Yes, this is a really important development. This isn't just a passive lining of your blood vessels. It's a dynamic, protective gel layer, a delicate but powerful barrier residing on the inner or luminal surface of your vascular endothelium.
A gel layer. Tell me more.
It truly is a remarkable and dynamic barrier. This gel layer, which can range from 0.1 to 1.2 micrometers in diameter, that's incredibly thin, is composed of a complex matrix of glycoproteins, polysaccharides, and hyaluronic acid. These components bind to ionic side chains and plasma proteins, creating a physiologically active structure right within your vascular space. Its functions are truly extensive and vital.
Like what?
Well, it plays a crucial protective role in transcapillary fluid exchange, acting as a gatekeeper. It precisely regulates microcirculatory flow, influencing how blood moves through your tiniest vessels. It also profoundly influences blood component rheology, how your blood literally flows and behaves.
And here's where it gets really interesting. You said this glycolytics helps preserve plasma oncotic pressure. How?
By binding circulating plasma albumin, essentially keeping that fluid-pulling protein where it needs to be within the vessel. It also decreases capillary permeability to water, effectively modulating the impact of plasma hydrostatic pressure on net filtration.
What's it's like an extra layer of control.
Exactly. This sophisticated regulatory function is sometimes described as the double barrier effect. Beyond fluid, it plays a critical role in modulating inflammatory processes by essentially enclosing inflammatory mediators, helping to prevent inappropriate leukocyte adhesion unless there's an actual acute inflammation or endothelial damage.
That's amazing.
Furthermore, it acts as a scavenger for signal transduction, helping to regulate local vasoactive responses to mechanical stress on the vessel walls. And it significantly aids in preventing blood components from sticking to the vascular wall, augmenting or improving laminar blood flow by creating a zone of exclusion between its surface and the center of the vessel.
So this newer understanding has actually changed things like the Starling equation.
It has. It led to a revised Starling equation, emphasizing the oncotic pressure right beneath this delicate gel layer in the subglycolytic space. It's a testament to how our understanding of the body's intricate systems continues to evolve.
Okay, beyond these fascinating microcirculatory dynamics, your body possesses an incredibly sophisticated system of neurohormonal regulation that provides the ultimate fine-tuning for fluid and electrolyte balance.
Absolutely. The sheer precision is astonishing. Normal daily alterations in your total body water are typically minute, a clear sign of this intricate control at work.
And a central player in this neurohormonal symphony is the renin-angiotensin-aldosterone system, or RAAS.
Yes, RAAS. This system is a key potent regulator of physiological sodium homeostasis. It doesn't just activate randomly, it kicks into high gear in response to conditions like hypotension or low blood pressure,
Right.
which is detected by specialized baroreceptors located in your heart and in the afferent arterioles of your kidneys. It also responds to systemic sympathetic stimulation, essentially your fight or flight response.
So when it's triggered, what happens?
Specialized juxtaglomerular cells within your kidneys spring into action, releasing an enzyme called renin. Renin then acts upon a precursor protein called angiotensinogen, cleaving it to form angiotensin I.
Angiotensin I.
Now, angiotensin has some minor local vasoconstrictor activity, but its primary role is as a precursor for something much more powerful, angiotensin II.
Ah, the big gun.
Exactly. This critical conversion primarily occurs in your lungs, catalyzed by an enzyme we often hear about, angiotensin-converting enzyme, or ACE.
ACE, right. So what does angiotensin II do?
Angiotensin II, once formed, is quite the potent molecule with widespread effects. First, it's a powerful vasoconstrictor, causing your blood vessels to narrow and thereby increasing blood pressure.
Okay.
Second, it directly stimulates your renal tubules, those tiny filtering units in your kidneys, to reabsorb both sodium and water, holding onto precious fluid. Third, it acts on your adrenal cortex, stimulating the release of aldosterone.
Aldosterone.
Aldosterone, in turn, provides an additional strong stimulus for sodium and water retention by your kidneys. Since sodium is one of the primary determinants of serum osmolality and water transport, the careful regulation of your extracellular volume is intimately linked to sodium homeostasis. That makes sense. This concept becomes absolutely vital when we consider things like perioperative sodium loading and selecting the right intravenous fluids during surgery.
Okay. Next up, we have the antidiuretic hormone pathway, or ADH pathway. This one's mainly about water balance.
Primarily, yes. This pathway is exquisitely sensitive. Even minute increases in serum osmolality, meaning your blood is becoming slightly more concentrated, are detected by specialized osmoreceptors in your hypothalamus, the control center in your brain.
And when that happens?
Your posterior pituitary gland, a small but mighty endocrine gland, releases ADH. This hormone then travels to your kidneys, causing specialized aquaporin channels within the renal tubules to transiently reabsorb large quantities of water.
Aquaporins, water channels.
Right. This action is crucial for preserving circulating blood volume and leads to a tremendous increase in urine concentration and osmolality, essentially making your urine much more concentrated.
Does ADH do anything else?
It does. Beyond its water retention role, ADH also acts as a potent arterial vasoconstrictor, playing an important role in preserving blood pressure during times of volume stress.
Interesting.
And while osmolality is the primary trigger, significant decreases in circulating blood volume detected by baroreceptors in your heart's atria, carotid body, and aorta also stimulate ADH release, though this mechanism is significantly less sensitive.
And does this trigger thirst too?
Yes. That same detection of increased serum osmolality also directly tells your hypothalamus to stimulate thirst, encouraging you to seek and drink more water. It's a coordinated response.
Okay, so RAS holds on to salt and water, ADH holds on to water and constricts vessels. What's the third part of this trifecta?
That would be the atrial natriuretic peptide pathway, or ANP. This system springs into action in response to the opposite conditions. Increased preload or hypervolemic states, essentially, when there's too much fluid volume stretching the heart.
So when the heart feels stretched.
Exactly. This extra stretch in your cardiac atrial walls stimulates the release of ANP from cardiac myocytes, which are your heart muscle cells.
And ANP does the opposite of RAS and ADH.
Pretty much, yeah.
Yeah.
Once released, ANP stimulates your kidneys to release both sodium and water, thereby effectively reducing circulating blood volume and taking some of the load off your heart.
Okay.
It also produces specific vasoactive responses in your kidneys' afferent and efferent renal arterioles to increase the glomerular filtration rate, or GFR, essentially increasing the rate at which your kidneys filter blood. And, importantly, it inhibits the release of both renin and ADH, further promoting fluid excretion.
So it's a counter-regulatory system.
Precisely. Conversely, during periods of decreased preload, those same atrial receptors inhibit the release of ANP, showing how the body constantly adjusts its fluid balance based on cardiac filling.
Wow. What this all adds up to is an incredibly precise and dynamic overall balance.
It really is.
Yeah.
These neurohormonal mechanisms, combined with countless other complex renal, hormonal, vascular, and metabolic processes, meticulously maintain your fluid and electrolyte balance.
The precision is amazing.
It is. In a healthy adult, the daily fluid inputs, the water and electrolytes you take in through nutrition and drinking, are almost perfectly matched by your outputs through sweat, respiratory losses, gastrointestinal losses, and urine. The system is so precise, in fact, that daily fluctuations in your total body water typically represent only about 0.2% of the total.
Only 0.2%.
Yeah. It truly is a marvel of biological engineering, a constant dance of regulation to maintain that internal ocean in perfect equilibrium.
Okay, so given this incredibly complex and meticulously balanced internal ocean, what happens when it needs a direct intervention, particularly during critical moments like surgery? This brings us to a surprisingly fundamental and often intense core debate in modern anesthetic practice: the optimal selection of intravenous fluids for perioperative management.
It's a huge topic. While there's universal agreement on the overall goals, maintaining intravascular volume, augmenting cardiac output, ensuring adequate tissue perfusion, there's a long-standing, often heated debate about the safety and efficacy of crystalloid solutions compared to colloid solutions for volume resuscitation.
Crystalloids versus colloids. Let's start by exploring crystalloids. What are they fundamentally?
Crystalloids are essentially aqueous electrolyte solutions, simple mixtures of salts and water, and they have been the absolute mainstay of volume resuscitation in surgical patients for over a century. They are the most common type of IV fluid you'll encounter.
And they have their well-defined preferred uses, right?
Absolutely. For conditions like dehydration, where there's a total body water loss leading to concentrated plasma-thin prolonged fasting, active gastrointestinal losses from vomiting or diarrhea, or conditions that increase your metabolism, isotonic crystalloids are ideal. They effectively hydrate the entire extracellular volume, restoring both water and electrolyte homeostasis to both the intravascular and interstitial spaces. They fill up the whole system, basically.
And they're also good for replacing active blood loss during surgery.
Yes, highly beneficial for replacing active intravascular losses, like during a hemorrhage. They provide immediate restoration of circulating vascular volume, help preserve microcirculatory flow, decrease the hormone-mediated vasoconstriction that the body triggers in response to stress, and correct the plasma hyperviscosity often associated with acute blood loss. They help keep the blood flowing smoothly, even when volume is lost.
Plus, crystalloids come with some clear practical advantages.
They do. They have a very low allergenic potential, meaning allergic reactions are rare. They're relatively easy for the body to metabolize and for the kidneys to clear when infused in appropriate volumes, especially compared to colloids. And they play a crucial role in helping to preserve overall electrolyte balance, even when there are active plasma losses during an operation.
Okay, but there must be downsides, otherwise there wouldn't be a debate. What's the main disadvantage?
The significant physiological disadvantage is this. Because isotonic crystalloids are designed to distribute evenly throughout the entire extracellular space, their ability to expand plasma volume, that crucial intravascular fluid, is quite transient.
Ah, so most of it leaks out.
A lot of it does. Due to their low molecular weight, these solutions dilute plasma proteins and lead to a loss of capillary oncotic pressure. As we discussed earlier with Starling forces, this dilution favors filtration.
Right, pushes fluid out.
Exactly, meaning approximately 75% to 80% of the administered crystalloid volume actually filters out of the blood vessels and into the interstitial space. So to achieve significant intravascular volume expansion, you often need to administer a much larger volume of crystalloid compared to a colloid.
Okay, that's a key difference. Let's delve into some specific crystalloids, starting with the most common one. 0.9% sodium chloride, famously known as normal saline, or NS.
Normal saline. The original crystalloid solution, developed based on in vitro erythrocyte studies over a century ago. And to this day, it remains the most commonly administered 5E fluid worldwide.
But you said it's considered the least physiologic. Why is that?
That least physiologic designation is critical to understand. Normal saline contains roughly equal concentrations of sodium and chloride, about 154 milliequivalents per liter of each.
Okay.
If you compare that to normal plasma, where chloride is typically around 103 millieql, you can see that NS delivers an extraordinarily high chloride load.
Much higher than normal.
Way higher. And this excess chloride is a major concern because it can contribute directly to acid-base imbalances, specifically leading to a dose-dependent hyperchloremic metabolic acidosis.
Acidosis, okay.
Even if the body's compensatory mechanisms manage to maintain a normal overall plasma pH, using NS for significant volume resuscitation, especially in acute losses, is associated with marked alterations in base excess due to that chloride load. This can even exacerbate fluid overload if, for example, a negative base excess is mistakenly used as a trigger for further fluid infusion.
And what about the impact on the kidneys?
The impact of this high chloride load on the kidneys is also substantial. It's thought that the excessive renal reabsorption of chloride increases vascular resistance in the renal arterioles, which in turn leads to a decrease in the glomerular filtration rate, or GFR, the rate at which your kidneys filter blood.
So it slows down kidney filtering?
Potentially, yes. Hyperchloremia may also impair the kidney's ability to properly handle bicarbonate, further complicating acid-base balance. What's more, the increased sodium load that comes with large volumes of 0.9% saline causes increased salt and water retention, leading to hemodilution and notably interstitial edema that can persist well into the postoperative period. A striking study showed that just 2 liters of normal saline administered to healthy volunteers contributed to a positive sodium and water balance that took up to 2 days to excrete.
2 days.
And this duration can be significantly prolonged in surgical patients. It really shows how much of an impact it can have.
So the clinical evidence surrounding normal saline and its renal impact, it's been pretty debated.
Extensively debated and often conflicting. For example, the SBLAD trial in 2015, which evaluated over 2,200 patients across 4 intensive care units, found that using buffered crystalloids did not reduce the risk of acute kidney injury compared to saline.
Okay, so no difference there, but you mentioned limitations.
Right. It's important to note the study's limitations. The median volume administered was relatively small, only about 2 liters, and high-risk patients with very severe conditions were excluded, which limits how broadly we can generalize its findings.
Got it. What about other studies?
A 2018 systematic review analyzing 15 studies with over 4,000 patients also concluded that low chloride solutions had no impact on mortality or the need for renal replacement therapy compared to high chloride solutions. But again, the investigators themselves acknowledged the generally low quality of the available evidence and insufficient statistical power due to various study design factors, like the low volume of fluids actually studied. So the picture remained murky for a while.
Then came 2 very influential trials that started to shift the conversation. The SALT-ED trial.
Yes, SALT-ED. Conducted in emergency departments involving over 13,000 patients, it compared balanced crystalloid administration against saline. It found no difference in hospital-free days, which was the primary outcome. However, a secondary outcome of the study powerfully demonstrated a lower incidence of major adverse kidney events within 30 days in the balanced crystalloid group. This was a statistically significant finding, suggesting a potential kidney protective effect.
Okay, lower kidney problems. And concurrently, the SMART trial.
Right, the SMART trial. It meticulously examined nearly 8,000 critically ill patients in 5 intensive care units and found that, compared to saline, balanced crystalloids significantly reduced major adverse kidney events within 30 days among critically ill patients.
So SMART and SALT-ED pointed towards benefits for balanced fluids.
They did. These 2 trials, published almost simultaneously, truly ignited the discussion and provided the strongest evidence yet for the potential benefits of balanced solutions, especially regarding kidney outcomes.
Yet, the debate continued, and larger analyses sometimes offered a different perspective.
That's the complexity of medical evidence. For instance, the Cochrane Collaboration Review in 2019, a highly respected and extensive analysis of 21 randomized controlled trials involving over 20,000 critically ill adults and children, concluded with a high degree of certainty that there was no advantage of balanced crystalloids over saline in preventing in-hospital mortality.
No difference in mortality. What about kidney injury?
While balanced crystalloids did reduce metabolic derangements in many of the component trials, the evidence for a difference in acute kidney injury incidence was less certain, showing no clear difference in that review.
And other meta-analyses.
Another large meta-analysis, this one looking at 9 studies with over 32,000 patients, also revealed no significant difference between balanced crystalloids and saline in terms of overall mortality, moderate to severe acute kidney injury, or the need for renal replacement therapy. Again, the authors emphasized the low quality of some of the evidence and the ongoing need for even larger, more definitive trials to settle the debate. So it's clear this is still a very active area of research and discussion.
Despite these mixed or seemingly inconclusive findings from some large trials, current recommendations still lean towards balanced fluids.
They do. Influential bodies like the Enhanced Recovery After Surgery, or ERS Society, and others continue to strongly recommend the use of balanced crystalloid solutions for perioperative fluid management and in situations requiring high-volume fluid resuscitation.
Why the strong recommendation if the big trials are mixed?
This strong stance is largely based on the abundance of observational data and the clear physiological rationale regarding the reduction of metabolic derangements, like that hyperchloremic acidosis, seen with balanced solutions compared to saline. It's an evolving field, and future ongoing trials will undoubtedly provide even more conclusive evidence to guide practice.
Okay. Now, it's important to remember that 0.9% normal saline does have its very specific and decided roles in modern anesthetic practice. It's not totally out.
Not at all. For neurosurgical patients, for example, its mild hyperosmolality makes it the preferred fluid, especially for those at risk of cerebral edema. It helps draw fluid out of the brain tissue.
Ah.
It may also be indicated for fluid management in patients with anuria, meaning they produce no urine, or those with end-stage renal disease who simply cannot excrete the potassium content that's found in more balanced crystalloid solutions. So while it's not a universal ideal, it definitely has its precise place.
And then there are hypertonic saline solutions, like 3% saline. These are different beasts entirely.
Absolutely. Typically 3% or greater concentrations of sodium chloride. These are sometimes used in carefully controlled low-dose infusions for trauma and head-injured patients.
How do they work?
They work by promoting significant volume expansion, essentially drawing fluid from the intracellular and interstitial spaces into the intravascular compartment due to a strong osmotic gradient. This can provide a crucial protective effect for patients suffering from intracranial hypertension by helping to reduce brain swelling.
But there are significant risks.
Significant risks. These include vascular irritation, a sudden and potentially dangerous fluid shift into the intravascular space, and the potential for severe dehydration of neural cells, which could lead to a devastating condition called osmotic demyelination syndrome. So their use is reserved for very specific high-stakes situations with extremely close monitoring.
Okay. Moving on to another common crystalloid, lactated ringer, or LR. What's the story here?
LR is a widely used electrolyte solution that contains sodium lactate, which acts as a bicarbonate precursor or buffering agent.
A buffer, okay.
This is a key feature, as it helps maintain the electrochemical balance and a more neutral pH for the solution, while also decreasing the anionic requirement for a chloride compared to saline. LR is relatively low cost and has actually been shown to be more effective than 0.9% saline in preserving intravascular volume during resuscitation, offering a more balanced approach.
Sounds pretty good. Are there drawbacks?
There are some important contraindications and cautions that clinicians must be aware of. It's generally not recommended for large volume administration in diabetic patients.
Why not?
Because the byproducts of hepatic lactate metabolism can undergo gluconeogenesis, which means they can actually create new glucose in the body, potentially impacting blood sugar control.
Ah.
Its infusion may also contribute to a mild metabolic alkalosis due to that alkalinizing effect of lactate.
And crucially, LR is mildly hypotonic, right? What does that mean?
It means it has a slightly lower osmolality than plasma. This characteristic means it can potentially cause transient serum hyposmolality, which in turn can lead to associated cerebral edema. As a result, it is generally considered contraindicated in patients with traumatic brain injury, TBI, or other neurovascular insults where brain swelling is a major concern.
And one more critical point about LR, something about blood products.
Yes, very important. LR contains calcium, which makes it absolutely contraindicated for infusion with citrated blood and blood products.
Why is that?
Citrate is a preservative added to blood that works by binding calcium, preventing coagulation. Adding more calcium from LR could disrupt this process and lead to unwanted coagulation within the blood product bag or tubing, compromising its effectiveness and safety. You cannot mix LR and blood.
Good to know. Finally, within the crystalloid family, we have solutions like Plasmolite A, Normasol R, and Isolite S. These sound like the most balanced ones.
They are widely considered to be among the most isotonic of the balanced salt solutions available, offering what many clinicians believe is the most optimal balance of electrolytes and pH closest to plasma.
And what are their advantages?
They boast the most favorable acid-base profile when compared directly to plasma, and they demonstrate a superior ability to preserve physiologic pH and renal perfusion compared to 2.9% saline.
Okay.
Furthermore, they utilize sodium gluconate and sodium acetate as alkalinizing buffers rather than lactate, which circumvents some of the issues we discussed with LR, particularly for diabetic patients. And because they do not contain calcium, these solutions are safely compatible with blood products, offering greater flexibility in clinical situations.
Okay, that covers the crystalloids. Now, let's turn our attention to the other side of the great fluid debate. Colloids. How are these fundamentally different?
Fundamentally different. Colloids are suspensions of high molecular weight molecules in electrolyte solutions. Their primary mechanism of action is fascinating. They produce intravascular volume expansion by directly increasing plasma oncotic pressure, that powerful osmotic pull we talked about.
The protein pull.
Exactly. And crucially, they interact with the endothelial glycocalyx, that protective gel layer, helping to decrease transcapillary filtration, meaning less fluid leaks out of the vessels compared to crystalloids.
So they stay in the blood vessels better.
Much better. This unique mechanism means that colloids are highly effective for rapid and sustained plasma volume expansion. Consequently, colloid solutions are often used perioperatively for what are known as their fluid-sparing effects compared to crystalloids.
Meaning you need less volume.
Right, you need to administer significantly less volume to achieve the same amount of intravascular expansion. Beyond packed red blood cells, which are a naturally occurring colloid, albumin is the only other naturally occurring colloid solution available for infusion. However, there are a variety of synthetic colloids also used worldwide. These solutions are generally classified by their molecular weight, their concentration, and importantly, their half-life in the body.
Let's delve into some of these specific colloids and their controversies. As you mentioned, their histories are quite telling. First, dextrans.
Dextrans. Among the oldest artificial colloids, first manufactured in the 1940s, they are high molecular weight polymers, typically between 40 to 70 kilodaltons, derived from the bacterial metabolism of sucrose. They are markedly hyperosmolar and generally have a half-life of roughly 6 to 12 hours within the body.
But they had problems.
Severe problems. Dextrans became notorious for their severe adverse effects. They are known to cause acute renal failure through multiple mechanisms, including indirect hyperosmotic renal injury and direct damage to the renal tubules due to their accumulation.
Kidney failure.
Yes. Their use was also associated with a variety of serious coagulopathic effects, meaning they interfered with blood clotting. This included impairing von Willebrand factor, activating plasminogen, interfering with normal platelet aggregation, and even adhering to the surface of platelets and red blood cells, which could interfere with accurate cross-matching of blood products.
So a lot of issues. Are they still used?
Thankfully, no. Due to this significant propensity to cause acute renal failure, induce severe anaphylactic reactions, and cause coagulopathy, dextrans are no longer used in modern clinical practice. A clear lesson learned from historical experience.
Okay. Next, we have gelatins, derived from bovine sources.
Yes, synthetic colloids derive from bovine components. They have a relatively lower molecular weight, typically 30 to 35 kilodaltons, compared to most other colloids. This smaller size contributes to their shorter half-life, usually around 2 to 4 hours, which means they provide a more limited duration of plasma expansion.
And did they have similar problems to dextrans?
Unfortunately, yes, similar patterns emerged. Like dextrans, gelatins have been found to interfere with platelet function, can cause nephrotoxicity, and have a high propensity for causing anaphylaxis, particularly if urea-linked formulations were used. There have also been theoretical concerns regarding their potential to transmit bovine spongiform encephalitis, or BSE.
Mad cow disease.
Right, although the actual risk remains unknown. A 2016 meta-analysis, although working with limited data, indicated an increased risk of anaphylaxis, renal injury, acquired coagulopathy, and even mortality when gelatin-containing plasma expanders were compared to crystalloids and albumin.
So what's the status of gelatins now?
Due to these ongoing safety concerns and a lack of sufficient evidence demonstrating any clear benefit from their use, the use of gelatins in clinical practice has been cautioned. This underscores a recurring pattern of synthetic colloids having unforeseen and serious side effects.
Now, hydroxyethyl starches, or HES, you said, have a particularly complex and controversial history.
Extremely controversial. These are synthetic macromolecules derived from starchy plants like potatoes or maize, which means they can potentially cause allergic reactions in sensitive patients. They are synthesized by substituting hydroxyl groups at specific carbon atoms and are classified by their molecular weight and substitution ratios. For instance, a higher C2-C6 ratio indicates that the HES will be more difficult for the body to metabolize and thus provide a longer duration of plasma volume expansion.
What's the core of the controversy?
The controversy runs very deep because many of the landmark initial studies that claimed to demonstrate their safety and efficacy were later retracted due to fabricated evidence.
Fabricated evidence, wow.
Yes, a profoundly disturbing history. Despite this, HES has been widely used globally, particularly in the European Union. Their clinical impact has been extensively studied due to their prevalence in perioperative and critical care settings.
And what did those studies find?
The first-generation HES solutions, such as hetastarches and hexastarches, which are the highest molecular weight solutions, were strongly associated with dose-dependent coagulopathy due to hemodilution, direct binding of clotting factors, interference with platelet adhesion, inhibition of fibrin polymerization, and significant alterations in plasma viscosity. They literally impacted the blood's ability to clot.
And the problems didn't stop there.
No. HES can accumulate in the body, forming interstitial colloid deposits in subcutaneous and other organ tissues, leading to severe pruritus or itching, and critically, nephrotoxicity or kidney damage. While it was initially thought that this effect was primarily associated with the prolonged metabolic profile of first-generation HES, subsequent studies have tragically shown that this accumulation and toxicity occur across all generations of HES.
All generations.
Yes. Furthermore, numerous randomized controlled trials have clearly demonstrated the significant risk of kidney injury, the need for dialysis, coagulopathy, increased susceptibility to sepsis, and even increased mortality associated with HES. These adverse impacts have even been shown to persist for up to 90 days after HES administration, demonstrating a long-term negative effect.
This led to significant regulatory actions, right?
Yes, very impactful actions. The U.S. FDA issued a black box warning for HES solutions in 2013, which is their strongest warning, specifically notifying the public of the risks of renal injury and increased mortality. Even more dramatically, the European Medicines Agency, or EMA PSA Committee, issued a sudden recommendation in January 2018 to fully suspend all HES solutions from the market.
A full suspension. Why such a drastic step?
It was a direct response to 2 drug utilization studies indicating that HES were still being used in critically ill and septic populations, despite the EMA's earlier 2013 recommendation against such use. It highlights the serious concern regulators had about the continued use of these fluids, despite known risks.
However, this decision faced continued debate and pushback.
It did. A notable group, which included one of the original authors of the 2013 Crystal trial, a major study on colloids versus crystalloids, challenged the EMA decision. They cited their earlier evidence, which had shown no difference in 28-day mortality or the need for renal replacement therapy among over 2,800 critically ill patients when comparing colloids to crystalloids.
But wasn't there a mortality difference later on?
Well, it's worth noting their study did show that 90-day mortality was reduced in the colloid group, as were vasopressor use and mechanical ventilation, days by day 28. So the picture remained complex, with some studies pointing in different directions depending on the time frame and outcomes measured.
Have further studies brought more clarity?
They've continued to try. A 2016 systematic review evaluated the relative risk of HES compared to crystalloids in patients undergoing elective non-cardiac surgery. It concluded that there was insufficient evidence to identify a significant difference in outcomes such as mortality, acute kidney injury, length of stay, or infection. This suggests that in lower-risk surgical settings, the risks might be less pronounced or harder to detect. And importantly, following the EMA decision, a study of over 1,000 patients undergoing abdominal surgery also found no difference in major postoperative complications when comparing HES to balanced crystalloids. So while the broader risks in critical illness are clear, their specific role in certain surgical contexts remains an area of ongoing investigation and debate.
Okay. Finally, we turn to albumin, a colloid with a very different profile. It's a blood product.
Yes, albumin is a fractionated blood product, meaning it's produced from pooled human plasma. It has a molecular weight of 65 to 69 kilodaltons, and crucially, it's heat-treated during its preparation to inactivate pathogens, which effectively eliminates the risk of disease transmission.
Where did it originate?
Commercially prepared albumin solutions were first developed in the mid-1940s, primarily as rapid plasma volume expanders for use in military trauma settings, favored for their ability to quickly restore circulating volume when blood transfusions were not immediately available.
How is it used today?
In modern anesthetic practice, albumin is often used as a volume expander in active loss situations that don't specifically require a red blood cell transfusion. It's known that even small volumes of albumin can provide a greater degree of intravascular resuscitation compared to equal or even larger volumes of crystalloid, making it quite efficient for plasma expansion.
But the cost is a factor.
A major factor. Albumin preparations are significantly more costly than crystalloid solutions. While it can be useful in some goal-directed approaches to reduce tissue edema, it still carries a risk for anaphylaxis or other immune-mediated reactions, though this is relatively rare.
And it has other functions besides volume expansion.
It does. Physiologically, albumin acts as a crucial carrier for a variety of protein-bound ionic substances, including many drugs and their metabolites, electrolytes, enzymes, and hormones. Thus, its administration may be advised specifically in the presence of hypoalbuminemia, where a patient has low albumin levels.
And there's something called the Donin effect.
Yes, a unique property. Albumin molecules possess a negative electrostatic charge and bind ions, which effectively increases plasma osmolality and expands intravascular volume. This phenomenon is known as the Donin effect, and it's a key reason why albumin is so effective as a plasma expander.
Now, one of the most famous studies involving albumin is the SAFE study. What did that show?
The SAFE study, the saline versus albumin fluid evaluation study, was a massive trial involving nearly 7,000 critically ill patients who were randomized to receive either 0.9% saline or 4% albumin solutions. The study famously demonstrated no difference in overall clinical outcomes between the two groups.
No difference.
Except, and this was a critical and highly significant exception, in cases of neurotrauma, patients in the albumin cohort actually had a higher incidence of mortality. This one finding created a very important caveat for albumin's use, particularly in head injury.
So when might albumin be preferred, given that finding?
Due to its targeted expansion of the intravascular space and its effect on oncotic pressure, colloids like albumin may be the preferred solution for replacing circulating blood volume in patients who are experiencing acute volume losses and, importantly, have an intact endothelial glycocalyx.
Intact glycocalyx is key.
Absolutely crucial. However, the use of albumin and other colloids in patients with existing endothelial injuries, for example, due to severe sepsis or uncontrolled hyperglycemia, may actually lead to pulmonary edema and other end organ complications, as the fluid can then leak out more easily into the tissues. Furthermore, administering colloid solutions to euvolemic patients, those with normal fluid volume, has even been known to contribute to ANP-mediated hypervolemic endothelial disruption. Therefore, practitioners are seriously cautioned to avoid colloids in patients with clinical conditions that are likely to precipitate endothelial injury, such as uncontrolled hyperglycemia.
When we weigh the cost versus benefit of albumin, what's the general consensus?
The evidence suggests an acceptable safety profile for albumin, and the administration of small allotments to volume-responsive patients is still advocated in some goal-directed approaches. However, due to insufficient high-quality evidence that clearly demonstrates superior benefits over crystalloids for general use, combined with their significantly higher cost, many clinical guidelines often conclude that their cost does not justify their routine use in critically ill patients. It becomes a very practical consideration.
Yet albumin does seem to have a specific role in sepsis. Why is that?
It's considered less likely to cause nephrotoxicity and to disrupt the vascular endothelium compared to some other fluids, giving it the potential to preserve renal perfusion in patients with septic shock. Later evidence even suggested that albumin administration may help preserve the integrity of the glycocalyx in early sepsis, which, as we discussed, is crucial.
So guidelines recommend it in sepsis.
Some do. The Surviving Sepsis Campaign in 2017 issued updated guidelines, which included a recommendation for albumin as a component of early resuscitation for septic patients requiring large volume crystalloid infusion, although they noted that the evidence for this recommendation was weak. The National Institute for Health and Care Excellence, or NICE in the United Kingdom, also recommends considering albumin for septic patients.
But other reviews are less conclusive.
Right. A 2018 Cochrane collaboration review comparing colloids to crystalloids in critically ill patients found that albumin produced no difference in 30 or 90-day mortality, the need for renal replacement therapy, or allergic reactions. So while some guidelines lean towards it in sepsis, further robust studies are clearly needed to definitively define albumin's precise role in both volume-responsive surgical patients and the broader critically ill population.
Okay, moving beyond the fluids themselves. The very act of surgery, particularly major surgery, throws a massive physiological curveball at your body's fluid balance and overall function. It truly is a surgical crucible, right?
Absolutely. It triggers incredibly complex physiological responses that profoundly impact vascular flow and the perfusion of your vital organs. This isn't just a physical incision, it's a systemic event.
And it all begins with the body's deeply ingrained stress response to surgery.
It does. When a surgical incision is made, it stimulates somatic and autonomic afferent nerves in that area. These signals race to the brain, activating what's known as the hypothalamic pituitary adrenal axis, or HPA axis.
The HPA axis.
This central nervous activation causes your hypothalamus to release corticotropin-releasing hormone, which then prompts your anterior pituitary gland to secrete adrenocorticotropic hormone, or ACTH. ACTH, in turn, travels to your adrenal cortex, eliciting the creation and release of cortisol.
And cortisol is a major player in this stress response. What does it do?
Cortisol stimulates protein catabolism, meaning it breaks down proteins. It also drives hepatic gluconeogenesis, which is the creation of new glucose from non-carbohydrate sources, and glycogenolysis, the breakdown of stored glucose.
So it mobilizes energy.
Exactly. Additionally, it increases the liver's production and release of plasma proteins, which contribute to increased plasma oncotic pressure, helping to preserve intravascular volume. These processes are, in essence, ancient evolutionary mechanisms designed to maintain energy substrate levels and circulating volume during times of increased metabolic demand, like injury or starvation.
But they can be problematic during surgery.
They can become maladaptive, particularly if they lead to hyperglycemia or vascular overload.
That hyperglycemia, high blood sugar, is a big risk factor.
A major risk factor for damaging or even destroying the delicate endothelial glycocalyx, that protective gel layer we discussed earlier. Beyond that, high blood sugar also impairs crucial wound healing, contributes to osmotic diuresis, which is excessive urine production due to high solute concentrations in the kidneys, and interferes with your body's immune responses, making you more susceptible to infection. So while seemingly adaptive, this stress-induced metabolic shift needs very careful management.
The physiological stimulation associated with surgery also triggers a significant catecholamine release. Adrenaline.
Yes, adrenaline and noradrenaline. Surgical trauma directly stimulates sympathetic nerves, leading to a substantial release of catecholamines from your adrenal medulla. This surge activates your sympathetic nervous system, resulting in predictable effects: an increased heart rate, increased systemic vascular resistance, meaning your blood vessels constrict, and microcirculatory vasoconstriction, which narrows your tiniest blood vessels.
That's the net result.
An increased basal metabolic rate, and, critically, a heightened oxygen demand throughout your body. The body is working much harder.
In addition to catecholamines, this sympathetic stimulation also triggers the release of antidiuretic hormone, or ADH again.
Yes, especially when combined with hyperosmolar conditions, that is, a high solute concentration in your blood. This causes further vasoconstriction, actively reabsorbs water in the kidneys, and can lead to increased potassium excretion. Depending on the magnitude of the surgical trauma and the resulting hemodynamic changes, this ADH release can unfortunately continue for hours into the postoperative period, significantly impacting the patient's fluid balance long after the procedure is finished.
And then there are the inflammatory mediators, specifically cytokines. Surgery causes inflammation?
It does. Surgical trauma and tissue injury prompt the local endothelial cells to release these powerful inflammatory compounds. This release contributes to hyperthermia, or fever, further increases oxygen demands throughout the body, and causes regional alterations in microcirculatory flow, meaning blood flow patterns change at the tissue level.
Is that always bad?
Not entirely. At low levels, this cytokine release is actually quite beneficial. It promotes local hemostasis, helping to stop bleeding at the injury site, and guides neutrophils, important immune cells, to where they're needed.
But if it gets out of control?
If this release becomes unrestricted or prolonged, it can be severely detrimental. It can contribute to widespread vasodilation, significant endothelial damage, increased fluid filtration out of the vessels, leading to pervasive tissue edema, insulin resistance, further intravascular fluid loss, hypotension, and ultimately decreased organ perfusion.
That sounds serious.
It is. In cases of severe tissue damage, particularly in major open abdominal surgeries, this can even promote an inflammatory loss of gastrointestinal endothelial integrity. This means the gut lining becomes compromised, potentially leading to the translocation of bacteria into the bloodstream and a full-blown systemic inflammatory response, with potentially devastating consequences.
Interestingly, you mentioned one of cortisol's most beneficial effects in this complex stress response is its anti-inflammatory action.
It is. Cortisol works by inhibiting the production, release, and vascular aggregation of these very inflammatory mediators, acting as a natural brake on the inflammatory cascade. This highlights the body's intricate, albeit sometimes maladaptive, attempt to regulate its own response to injury.
These complex physiological responses during surgery directly influence fluid volume shifts, right?
Absolutely. During periods of hypovolemia or acute hemorrhage, for example, a decreased capillary hydrostatic pressure, that pushing force actually favors absorption. This leads to what's often termed an autotransfusion.
Autotransfusion.
Yeah, where fluid volume moves naturally from the interstitial space back into the intravascular space, a crucial compensatory mechanism to try and maintain blood volume.
Conversely, what happens with hypervolemia or vascular overload?
You see a marked increase in that capillary hydrostatic pressure, combined with a dilutional decrease in plasma oncotic pressure because the proteins are now spread thinner. These conditions strongly favor filtration, meaning fluid is pushed out of the vessels, overfilling the interstitial space and overwhelming the lymphatic system's ability to drain it.
And this leads to interstitial edema, fluid in the tissues. What are the consequences of that?
The consequences are severe. This fluid accumulation is a primary cause of tissue congestion, can lead to the collapse of tiny capillaries, significantly impairs the removal of waste products and the exchange of vital nutrients, decreases microcirculatory flow, and ultimately results in tissue ischemia, meaning the tissues are starved of oxygen and nutrients. Essentially, the very fluid meant to support life ends up suffocating the tissues.
Now let's turn our attention to laparoscopic surgery. It's minimally invasive, but presents its own distinct set of challenges.
It does. It's generally preferred due to its less invasive approach, which typically results in a reduction in direct tissue damage, less blood loss, and a decrease in the release of inflammatory mediators, particularly cytokines. These are significant advantages for patient recovery.
But there are unique risks, primarily due to pneumoperitoneum, that's inflating the abdomen.
Exactly. Inflating the abdomen with gas, usually carbon dioxide, to create a working space for the surgeon. This increased intra-abdominal pressure causes a direct mechanical suppression of splanchnic blood flow. That's the blood flow to your abdominal organs like the gut and liver.
So it squeezes the blood flow to the gut.
Right. This can lead to transient splanchnic ischemia and significant microcirculatory changes in these vital areas.
And there's a risk of ischemia-reperfusion injury.
Yes. The sympathetically mediated vasoconstriction of the splanchnic circulation, induced by the pneumoperitoneum, effectively sacrifices gut mucosal tissue perfusion. This predisposes the delicate gastrointestinal epithelium to ischemia-reperfusion injury when vascular flow is restored at the end of the procedure.
What about other effects?
During the insufflation of the abdomen, especially if it's done rapidly or to high pressures, typically above 12 to 15 mmHg, the peritoneal and mesenteric afferent receptors can stimulate a vagal response, which can lead to undesirable drops in heart rate and blood pressure.
And the impact on cardiac function during pneumoperitoneum is multifaceted.
It is. Abdominal insufflation contributes to a significant increase in central venous pressure, or CVP, as blood is shunted from the compressed splanchnic circulation into the thorax. This elevation in right ventricular preload also stimulates the release of AMP, as the heart senses increased volume.
But paradoxically, it can also decrease preload.
Yes, increased intra-abdominal pressures can also contribute to a decrease in cardiac preload by physically impeding venous return to the heart.
And there's a serious potential for cardiac collapse.
If insufflation pressures are high enough to compress the inferior vena cava, particularly in patients who are already hypovolemic, yes. Also, afterload, the resistance your heart has to pump against, is markedly increased due to both elevated intrathoracic pressure and compensatory increases in systemic vascular resistance. This significantly contributes to a reduction in stroke volume, the amount of blood pumped with each beat.
So, less blood pumped per beat. Does blood pressure go down?
Curiously, no. While vascular flow may be decreased, arterial pressure is often elevated because of that increased systemic vascular resistance.
Right, and studies show it affects heart function even in healthy patients.
Yes, a study specifically on the impact of pneumoperitoneum in healthy ASA Cayenne 2 patients found that insufflation to pressures of 10 to 15 mmHg significantly decreased both right and left ventricular ejection fractions, indicating a direct impact on heart function.
How do patients compensate?
Patients with normal myocardial function are generally able to compensate for these hemodynamic alterations with an increased heart rate, tachycardia, and increased left ventricular stroke work, thereby preserving overall cardiac output. However, this comes at the expense of increased oxygen demand on the heart.
But what about patients with existing heart problems?
Critically, patients who enter surgery with volume overload or pre-existing decreased ventricular function may sadly develop cardiac failure as a direct result of their inability to compensate for these significant changes.
Fortunately, clinicians have developed effective anesthetic interventions to mitigate surgical stress, like medications.
Right. Medications such as opioids and dexmedetomidine are known to be very effective at reducing those HPA-mediated stress responses we discussed. However, modern enhanced recovery strategies often discourage the administration of very large doses of opioids due to their side effects.
What about regional anesthesia?
Neuraxial anesthesia, which includes techniques like spinal or epidural blocks, is a powerful tool because it directly helps to mitigate the spinal cord transmission of autonomic afferent impulses that would otherwise stimulate the HPA axis. This effect is most pronounced in procedures of the lower extremities and pelvis, providing a blunting of the stress response at its source.
And dexmedetomidine.
Dexmedetomidine, which is a sedative and analgesic, can be used as an anesthetic adjunct or even as a premedication. It provides valuable opioid-sparing analgesic effects and helps to attenuate the significant hemodynamic stress associated with laparoscopic procedures.
All of these physiological changes, responses, and potential complications are intricately linked to the concept of goal-directed fluid management, or GDFT.
Absolutely. The core idea is that judicious and timely administration of fluids, combined with precise vasoactive support medications that act on blood vessels tailored to meet defined perfusion targets, has been shown to powerfully support oxygen balance throughout the body and significantly mitigate the intense neuroendocrine response to surgical stress. It's about being proactive and precise.
And maintaining normal fluid volume, euvolemia, is key for the glycocalyx.
Crucial. Maintaining euvolemia throughout the entire perioperative period directly helps to preserve the integrity of the delicate endothelial glycocalyx and its associated microvascular functions. This comprehensive approach is all about minimizing the internal battle the body wages during surgery, fostering a smoother recovery.
The history of fluid management in medicine is a truly fascinating journey, marked by a dramatic evolution from rigid, formulaic approaches to the highly personalized precision we strive for today. Let's talk about those historical approaches, the one-size-fits-all era.
Right. For much of the last 60 years, clinical practice relied heavily on formulaic, fixed-volume methods designed to standardize fluid administration for all surgical patients, often with little regard for their individual baseline volume status, their unique myocardial or renal function, or their specific vascular tone.
And they use specific calculations, like the 4-2-1 calculation.
Exactly. Perhaps the most ubiquitous was the 4-2-1 calculation for determining maintenance fluid requirement. 4 milliliters per kilogram per hour for the first 10 kilograms of body weight, then 2 milliliters per kilogram per hour, and finally 1 millikilogram, 0 kilogram for every kilogram over 20 kilograms.
And they calculated a fluid deficit based on fasting.
Right. The estimated fluid deficit was simply calculated by multiplying that maintenance fluid requirement by the number of fasting hours prior to surgery.
They also had very specific guidelines for replacement of surgical losses based on trauma.
They did, estimated based on the perceived degree of surgical trauma. For superficial trauma, 1 to 2 milliliter. Minimal trauma, 2 to 4 milliliter. Moderate trauma, 4 to 6 milliliter. And for severe trauma, like major open abdominal surgery, it could be as high as 6 to 8 milliliter.
And what about replacing blood loss?
The standard recommendation for replacement of blood loss was a 3.1 ratio for crystalloid, 3 milliliter of crystalloid for every 1 milliliter of estimated blood loss, or a 1.1 ratio for colloid or blood products.
What was the theory behind all this? The fluid debt theory.
Exactly. This theory posited that patients who had been fasting prior to surgery incurred a significant preoperative fluid debt, and therefore required substantial volume preloading to help maintain physiological stability and homeostasis throughout the procedure.
But modern science challenges this.
Rigorously challenges this assessment. This formulaic approach simply does not adequately account for the unique cardiovascular and renal function in individual patients, nor does it accurately reflect the true physiological impact of fasting in most elective surgical patients. Indeed, the routine and often arbitrary use of preemptive fluid administration to correct these perceived fasting deficits frequently contributed directly to perioperative complications associated with fluid overload.
And giving fluid prophylactically can actually be harmful, now we know.
Yes, crucially. Current knowledge now definitively indicates that prophylactic volume administration in euvolemic patients, those who already have a normal fluid volume, actually creates a substantial and unnecessary risk of disrupting the delicate endothelial glycocalyx and contributing directly to pathological fluid overload. It's a complete flip from what was once standard practice.
But some patients might still be dehydrated before surgery.
Of course, this newer data doesn't entirely discount the possibility of genuine hypovolemia. However, given the substantial and proven risks of arbitrary fixed-volume fluid administration, current evidence strongly encourages the careful utilization of dynamic hemodynamic measures. These measures help to precisely evaluate fluid responsiveness only in those patients who actually have active preoperative volume losses, ensuring that fluid is given only when truly needed and beneficial. Precision is key.
And what about bowel preparations? They can cause fluid loss.
They certainly can. The use of these preparations, often to clear the bowel before surgery, can unfortunately cause excessive fluid losses. As a direct result, modern enhanced recovery strategies now focus on reducing fasting times and carefully evaluating the necessity of hypertonic bowel preparations. For instance, the practice of prophylactic bowel preparation alone prior to colorectal surgery has actually been shown not to decrease postoperative complications.
So bowel prep alone isn't helpful for infection. What about combining it with antibiotics?
That's the key. More recent, robust data from the ACS NSQIP review showed that while bowel preparation alone conferred no benefit against infection, the combined use of bowel preparation and prophylactic oral antibiotic therapy did significantly reduce the incidence of surgical site infection, better than antibiotic preparation alone.
So the combo works.
Yes. And the 2019 practice guidelines of the American Society of Colon and Rectal Surgeons now strongly support this combined approach for patients undergoing elective colorectal surgery. The adoption of more isotonic bowel preparation solutions may also help mitigate some of the excessive fluid losses associated with older hypertonic agents.
Okay. Another historical concept that's been reevaluated is the third space concept. What was that about?
This idea emerged in the 1960s, positing a non-functional component of the extracellular volume. Before we fully understood the neuroendocrine stress response, the original study hypothesized that a redistribution of extracellular fluids contributed significantly to the tendency of post-operative patients to retain sodium and water.
How did they study it?
Investigators attempted to identify fluid redistribution by excluding fluid administration and using isotope tracers. They concluded there was a measurable deficit in functional extracellular volume that couldn't be attributed to blood loss. Thus, they termed this unaccounted-for fluid as being sequestered in a third space.
And this became justification for giving lots of fluid.
Unfortunately, yes. The concept became a widespread justification for the liberal, often excessive, use of perioperative fluid administration, with the idea of compensating for this perceived redistribution.
But that was wrong.
Tragically wrong. The practice of routinely replacing these third space deficits became deeply entrenched. However, fluid management techniques that continue to account for this third space have since been shown repeatedly to result in poor clinical outcomes and gross fluid accumulation, often leading to a staggering 10 kilograms or more of perioperative weight gain. It truly highlights how a flawed theoretical concept can lead to significant patient harm.
And that 3.1 crystalloid ratio for blood loss also led to too much fluid.
Often, yes. That ratio was introduced to preserve intravascular volume while accounting for crystalloid filtration. But more recent evidence demonstrates the actual observed ratio needed is often less than 2.1. So even that seemingly precise ratio frequently led to over-administration.
A significant limitation of these historical methods was their reliance on static monitoring parameters like MAP, CVP, and urine output.
Yes, a major limitation. Despite their obvious value in standard monitoring, these static indices have proven quite unreliable as precise indicators of actual volume status.
How so? For MAP?
Well, a hypotensive patient might have relative hypovolemia, meaning low pressure due to altered vascular tone or poor heart function, even with adequate or excessive volume. Conversely, patients truly needing preload might maintain normotension temporarily due to compensation. Historically, this often led to treating hypotension with fluid regardless of the cause.
What about CVP?
Central venous pressure is also valuable, but heavily dependent on venous return, and baseline values can be altered by many conditions like heart or lung disease. Studies in critically ill patients showed only about half with low CVP were actually fluid responsive, so using it as a fluid target can easily lead to overload.
And urine output isn't reliable either.
Not as a sole indicator of volume status, no. It can be impacted by many factors, including the stress response and ADH levels. Giving large volumes to oliguric patients with high ADH might just expand the interstitial space, causing edema, not improving circulation. ADH effects can persist postoperatively, making it hard to excrete that excess fluid. Reviews have shown no difference in renal failure rates between restrictive management and conventional techniques aimed at reversing oliguria.
So the old ideas about kidneys easily filtering excess fluid and large volumes being protective are challenged.
Strongly challenged. The evidence now suggests the opposite can be true.
So the bottom line on historical approaches is pretty clear.
Undeniably clear. Intravenous fluid, like any drug, has indications, benefits, but also significant dose-dependent side effects. There's now widespread recognition of the serious consequences of inappropriate fluid administration.
Consequences like what? Let's start with under-resuscitation.
Giving too little fluid leads to hypovolemia, decreased microvascular perfusion, reduced oxygen delivery, and reduced tissue perfusion. This can cause severe end-organ complications: postoperative nausea and vomiting, renal dysfunction, myocardial ischemia, and hemoconcentration, increasing the risk of blood clots.
And the flip side, over-resuscitation.
Equally dangerous, if not more so in some ways. It can cause vascular overload leading to acute congestive heart failure, microvascular congestion also decreasing oxygen delivery, disruption of the delicate endothelial glycocalyx, altered coagulation, and potential hemorrhage. It causes hemodilution leading to anemia, low platelets, altered viscosity, and decreased oxygen carrying capacity.
And effects beyond the cardiovascular system.
Oh yes. Decreased gut motility leading to ileus or anastomotic leaks, increased infection rates, poor wound healing, decreased organ perfusion, increased lung water leading to prolonged ventilation and pneumonia risk, hepatic congestion, and even abdominal compartment syndrome. The stakes are incredibly high.
This brings us squarely to the new frontier: perioperative goal-directed fluid therapy, or GDFT. This is the modern approach.
It is. The profound impact of GDFT on clinical outcomes has made it a crucial component of modern anesthetic practice, especially within outcome-driven care like ERS. While achieving optimal balance is challenging with only standard monitors, research consistently shows GDFT reduces complications, supports timely bowel function recovery, and improves overall survival rates.
Where did this idea originate, the foundational research?
Much of it came from a 1980s trial by Shoemaker and colleagues. This pioneering study evaluated targeting supernormal hemodynamic and oxygen transport values in high-risk surgical patients.
Supernormal.
Yes, based on the observation that survivors of high-risk surgeries consistently had greater oxygen delivery, arterial oxygen content, and cardiac index than non-survivors. By using pulmonary artery catheters preoperatively to augment cardiac index and oxygen delivery, they significantly impacted survival. Patients in the PAC group had reduced mortality, shorter ICU stays, and fewer complications.
So Shoemaker's work was fundamental.
Highly valued for its fundamental contribution, yes. While supernormal targets aren't advocated anymore, his work laid the groundwork for personalized fluid management.
But concerns about supernormal targets led to refinement.
They did. The Mixed Venous Oxygen SVO2 collaborative group in 1995 studied over 10,000 ICU patients and concluded that maintaining normal, rather than supernormal, values yielded the same positive results. This indicated little benefit in force-feeding oxygen during high consumption periods. The focus shifted to optimal, balanced delivery.
And GDFT gained traction from there.
Rapidly. It became a subject of broad interest and intensive research. Its utility and the growing evidence catalyzed collaborative efforts between intraoperative and postoperative care providers. Concerns about invasive monitoring, like the Pacifier, spurred development of minimally invasive and non-invasive technologies, like those based on pulse contour analysis, pioneered by researchers like Canison.
So GDFT is now widely adopted.
Yes, widely adopted as a standard of care in Europe and readily accepted as a guideline in the United States. More recent studies have continued evaluating it, particularly in sepsis. Interestingly, a meta-analysis in early septic shock found GDFT yielded no difference in outcomes compared to improved standard care, possibly because standard care has incorporated many GDFT principles. The Surviving Sepsis campaign now recommends using dynamic variables like MAP and CVP changes to guide fluid responsiveness.
It's interesting that early GDFT trials often resulted in less fluid being given than the standard liberal approaches at the time.
That's a key point. It strongly highlighted the problems with fluid over-resuscitation.
And this led to studies specifically on fluid restriction.
It did, over the past decade. However, analyzing restrictive management was tricky because the definition varied wildly. One study's liberal was almost identical to another's restrictive.
So how do we define it better now?
The contemporary solution is using perioperative weight gain as a reliable surrogate indicator for hypervolemia, offering a much more objective measurement.
And this led to the zero balance approach.
Exactly. This aims to rigorously avoid surplus fluid, striving for true normovolemia, measured by maintaining preoperative body weight. Most techniques involve a basal infusion plus 1.1 replacement of measurable losses. Early studies showed this decreased postoperative morbidity compared to standard care.
What about combining GDFT with restriction, like an ERO?
An important trial evaluated GDFT within a fluid-restricting ERS protocol versus the ERS protocol alone for colectomy patients. The GDFT group got more fluid and had better aortic flow, but crucially there was no difference in recovery scores, complication rates, or length of stay.
So the benefit might be more nuanced within an already optimized protocol.
It suggests that, yes, meta-analyses examining GDFT in major surgeries generally show positive results. Reduced complications, including AKI and shorter hospital stays. Some showed reduced mortality, others showed reduced morbidity without affecting mortality. It's complex.
But then the RELIEF trial complicated things.
It did. This large trial compared restrictive versus liberal fluid therapy in major abdominal surgery and found restrictive management was associated with an increased risk of acute kidney injury and conferred no benefit for 1-year disability-free survival.
So too restrictive is also bad.
Precisely. It added caution to the debate. A subsequent Cochrane analysis comparing restrictive therapy to GDFT concluded existing data are insufficient to determine superiority, highlighting the need for more research.
And then there was that registry study showing a U-shaped distribution.
A fascinating insight from over 92,000 patients. It clearly showed both liberal and overly restrictive fluid therapy produced greater morbidity, mortality, longer stays, and higher costs than fluid optimization.
The Goldilocks zone.
Exactly. There's a just right sweet spot.
So what are the current recommendations? GDFT for high risk, zero balance for low risk.
That's one approach. The Fedora trial notably showed GDFT benefited even low to moderate risk patients, reducing complications and length of stay. Reviews now often illustrate combined strategies, using elements of zero balance, avoiding weight gain, with GDFT, targeted hemodynamics, sometimes called goal-directed fluid restriction.
And consensus statements.
A joint consensus on colorectal surgery by Acer and POQI recommends GDFT as the strategy of choice, but concedes zero balance may be an acceptable alternative.
So the ultimate aim of GDFT is?
To utilize individualized hemodynamic endpoints to precisely support oxygen transport balance, minimize oxygen demand while optimizing cardiac output, tissue oxygenation, blood flow, nutrient delivery, and end organ perfusion. This augments the patient's ability to tolerate surgical stress, improving outcomes.
And the measured outcomes of GDFT are quite significant.
Truly impressive. Decreased infection, ventilation duration, PONV, coagulopathy, hemorrhage, improved bowel motility, fewer cardiovascular respiratory complications, reduced anemia, hypotension, shorter hospital ICU stays, fewer UTIs, reduced renal impairment, and lower mortality in very high-risk patients. Profound benefits.
How do these GDFT protocols work in practice? It's algorithmic.
Largely, yes. Success stems from a systematic algorithmic approach. It evaluates fluid responsiveness, identifies support needed when fluid isn't the answer, and optimizes oxygen transport. It removes much of the guesswork.
How does it typically start?
Often with a baseline assessment of target hemodynamic measures, followed by a small, controlled fluid bolus, maybe 200-250 millil.
Why the small bolus?
Crucially, to assess the patient's position along the Starling curve, are they fluid responsive or not? By integrating clear triggers, small boluses, and defined targets for stopping fluids, GDFT provides measurable endpoints to assess response and prevent overload. The protocols also prompt consideration of vasoactive or inotropic support if fluids aren't enough.
And it requires constant reassessment.
Yes. Most protocols promote reassessment of preload responsiveness and oxygen delivery every 5-10 minutes. This aids timely administration of fluids and other interventions like vasoactives, preserving perfusion.
This level of precision fundamentally relies on modern hemodynamic monitoring.
Absolutely. These modalities provide measurable clinical endpoints, guiding initiation and cessation of fluids. Recognizing endpoints and manipulating targets allows definitive interventions. Fluid, vasoactives, inotropes, transfusion. Measures of responsiveness, oxygen transport, and microvascular flow-focused delivery to ensure optimal volume and mitigate mismanagement consequences.
The cornerstone for understanding fluid responsiveness is rooted in the Starling mechanism. Can you explain that simply?
Sure. It describes the relationship between how much the left ventricle fills with blood at the end of diastole LVEDV and how strongly it contracts, measured by stroke volume. Up to a point, increasing the filling preload stretches the heart muscle fibers, optimizing their overlap and increasing contraction force. The heart compensates for more volume by pumping harder.
Up to a point.
Exactly. There's a limit. Beyond a certain stretch, the muscle can't generate more force. Further increases in preload yield no more increase in stroke volume. This is shown on the classic pressure-volume curve.
And the curve has two parts.
Right. The ascending portion represents preload dependence. Patients here will respond to fluid by increasing stroke volume. Their heart can pump more. The plateau portion represents preload independence. Patients here cannot generate more force with more fluid. Giving them fluid won't help and can cause overload.
So knowing where a patient is on their curve is critical.
Paramount. Patients with normal function have a long ascent. They're on the physiologic curve. Patients with heart failure are on the pathophysiologic curve, a short ascent and early plateau. They tolerate very little fluid before overloading. Poor compliance means even small volumes can push them from dependence to overload.
Which underscores the importance of those small GDFT boluses.
Precisely. Differentiating dependence from independence is vital for tailoring interventions and preventing overload. Failing to recognize independence in hypotensive patients often leads to inappropriate, harmful fluid administration.
Okay, let's talk about the technologies. Dilution technique and devices are invasive.
Yes, these are typically invasive or calibrated. The core principle is introducing a fixed volume of injectate cold saline or a chemical and measuring cardiac output based on how quickly it passes through the heart, using time temperature or concentration time curves.
The classic example is the pulmonary artery catheter, PC.
Right, the Swan GANs. Chilled injectate goes into the right atrium, temperature is measured in the pulmonary artery. CO is calculated from the time temperature curve. It's the most invasive, giving comprehensive data on function, pressures, and lung water, but carries significant risks like bleeding, rupture, thrombus, infection, arrhythmias.
What are some less invasive calibrated systems? The PICO system.
Yes, PICO uses calibrated pulse waveform analysis via central venous and arterial lines. Calibration uses transpulmonary thermodilution. It measures responsiveness, contractility, preload, afterload, lung water. The PulsioFlex platform integrates more data too.
And the volume view set.
From Edwards Life Sciences, similar idea. Femoral arterial catheter with thermistor plus a central line. Uses transpulmonary thermodilution. The EV1000 monitor integrates invasive, non-invasive data for responsiveness, global hemodynamics, tissue oxygenation. Very comprehensive.
And the LIDS 2 plus Pulsio system.
From LIDSIO. Also calibrated pulse waveform analysis, but uses chemical dilution lithium chloride via venous access, measured by an arterial sensor. Software evaluates responsiveness and can calculate oxygenation with blood gas data. The Lid County platform integrates more, like depth of anesthesia.
Okay, moving to less invasive methods, pulse contour analysis. How does this work?
This provides dynamic measures of preload responsiveness by quantifying waveform changes, arterial, capnography, pulse oximetry, associated with cyclic breathing pressure changes.
And the key measures are things like PVI, SVV, SPV, PPV.
Exactly. Plethysmography variability index, PVI, stroke volume variation, SEV, systolic pressure variation, SPV, and pulse pressure variation, PPV. These are valuable for real-time assessment of response to fluids and vasoactives, often using minimally invasive or non-invasive tech.
What are the advantages of non-invasive monitoring here?
Favorable low-risk profile, plus the ability to continue monitoring post-operatively. Evaluating hemodynamics throughout the perioperative period ensures GDFT continuity and promotes enhanced recovery.
How does the physiology work? The breathing cycle changes things.
Yes, it's based on cyclic intracardiac pressure changes during ventilation. In mechanically ventilated patients, inspiration increases pleural pressure, augmenting left ventricle filling due to pulmonary vein compression and restriction of RV filling, enhancing LV compliance. This increases stroke volume. During expiration, SV falls as the reduced RV preload transits the heart.
And this variation is more prominent in hypovolemia.
Significantly more prominent, yes, due to A, increased intrathoracic pressure, decreasing RV filling, B, greater inspiratory impact on RV afterload if alveolar pressure impedes RV ejection, and C, greater LV contractility response to the preload bolus if the patient is preload dependent. The monitors capitalize on these changes.
How predictive are these measures? Is there a threshold?
Generally, values greater than 13% or 14% for PVI are considered predictive of fluid responsiveness. However, there's a well-documented gray zone, typically 9% to 13%, where accuracy drops maybe 25%, fail to predict accurately. Correlation with other measures or clinical judgment is needed there.
And there are known limitations to these dynamic variables.
Absolutely. They aren't universally applicable. Spontaneous ventilation causes different, less reliable variations. Small tidal volumes, 8 millilkg, might not create enough pressure change. Open chest conditions negate the principle. Sustained arrhythmias cause variability unrelated to fluid status. High PEEP can falsely elevate values. Right heart dysfunction can mimic volume responsiveness. Clinicians must consider these.
What devices use arterial waveform analysis?
Current applications use specialized sensor transducers with monitoring platforms and proprietary algorithms. Examples: FlowTrack with EV1000 Hemisphere, Edwards; ProAQT with PulseoFlex Pulsion; LID-Carapid Pulse Echo, LID-ECO.
And truly non-invasive monitors.
Yes, the ClearSight system, Edwards, uses a finger cuff and volume clamp method to get a finger arterial waveform, reconstructs it to a brachial waveform, and uses a model for CO measures. The CNAP sensor, CN Systems, uses similar tech.
Can we quickly review some common hemodynamic measures and normal ranges?
Sure. COCI, cardiac output index, normal CI 2.54 Lmin/Form, DO2I, oxygen delivery index, normal 650 mil in Lmin/m, EVLWI, extravascular lung water index, normal 3 to 7 mil in Lmin/m, FTC, corrected flow time, normal 360 meters.
Okay, keep going.
GDI, global end diastolic index, normal 680-800 mil in ml/m, O2 ER, O2 air, oxygen extraction ratio, normal 22%, 3%, PV, change in peak velocity, 12% predicts responsiveness, PPV for PP, pulse pressure variation, 13% predicts responsiveness.
Almost.
PVI, plethysmography variability index, 14% predicts responsiveness.
Right.
SCVO2, central venous O2 sat, normal 70%. SPV, systolic pressure variation, 14% predicts responsiveness. SVSVI, stroke volume index, normal SV 6100 ml beat.
Last view.
SVR-SVRI, systemic vascular resistance index, normal SVR 800 1200 dyne sec A1. SVO2, mixed venous O2 sat, normal 60-80%, measured PA. SVV, stroke volume variation, 13% predicts responsiveness. Each tells a vital story.
Beyond pulse contour, esophageal Doppler and echocardiography offer powerful insights.
Incredibly powerful. Esophageal Doppler uses ultrasound to assess aortic blood velocity, giving real-time LV function, aortic compliance, and dynamic measures like FTC, SV, profundus PV, less invasive direct measurement, standard in the UK.
And TE.
Transesophageal echocardiography, TEE, is considered a gold standard for direct evaluation of cardiac function and volume status, though use requires specific board certification. It provides invaluable real-time visualization: ventricular size, systolic diastolic function, valves, volume, wall motion, cardiac handling of fluids, a direct window into the heart.
What about measures of transthoracic impedance, ICG-TEB? How does that work?
Thoracic impedance cardiography, ICG, or thoracic electrical bioimpedance, TEPB, uses differences in electrical conductance between tissues related to hemodynamics.
How is it measured?
Paired surface electrodes on the neck and diaphragm transmit a low-level alternating current. It seeks the path of least resistance. Inside sensors measure ECG and impedance. Variations in impedance with blood flow during the cardiac cycle are mapped and integrated with software to get CO and other parameters.
Are there limitations?
Yes, especially with change-of-phase devices.
Yeah.
Interference from effusions, arrhythmias, aortic valve issues, aneurysms, obesity, movement artifacts. Multiple devices exist, like Asculon, BioZ, Nicus, Starling SV, Task Force.
Finally, measures of tissue oxygenation. These are key targets for GDFT.
Yes, using oxygen transport measures as targets has long been known to impact survival in high-risk and critically ill patients. These measures evaluate global tissue oxygen balance by measuring arterial, mixed venous, central venous blood gases, and calculating oxygen consumption, VO2, and delivery, DO2.
How are they calculated?
Integrated invasive technologies combine data from invasive lines, PEC CVC arterial line, with blood gas data inputs to calculate these measures. The primary GDFT goal is maintaining oxygen transport balance, optimize DO2, fluids, CO, flow, transfusion, and minimize VO2, opioids, beta blockers, normothermia.
And blood loss is a major factor here.
Absolutely. Active blood loss imbalances oxygen transport by losing both volume and oxygen carrying capacity. Judicious use of packed red blood cells to optimize DO2 is a critical, often controversial consideration in perioperative fluid management.
Now, all this advanced understanding isn't happening in isolation. It's fundamental to broader programs like enhanced recovery after surgery or ERS.
Exactly. Optimal perioperative fluid replacement is a fundamental component of ERS. ERS is a proactive, multimodal pathway aimed at improving surgical outcomes. Protocols incorporate best practices for optimal fluid therapy, reducing surgical stress response, promoting non-opioid pain modalities, and maintaining baseline organ function.
What are the ultimate goals of ERS?
To decrease post-operative complications, accelerate recovery, and promote early mobilization and hospital discharge. A growing body of evidence supports ERAS based on improved outcomes and decreased healthcare costs.
Where did ERS come from?
The origin of ERAS is insightful. Danish colorectal surgeon Henrik Kellet asked in the 90s, "Why is the patient still in the hospital?" He found causes were multifactorial, but often boiled down to delays in gut function and mobility. Protocols were developed to address these issues and promote faster recovery.
And it's applied broadly now.
Dramatically expanded, initially for colon resection, now used for vascular, esophageal, pancreatic, gastric, urologic, gynecologic, orthopedic, bariatric surgeries. ERAS programs are established worldwide. The ERAS Society has 22 specific treatment items.
Is there strong evidence for ERS?
Yes, a 2009 consensus review by Lassen et al. Showed optimal care with ERAS protocols for colorectal surgery. 15 of 20 items reviewed suggested strong evidence for benefit and improved outcomes. Successful implementation requires a committed multidisciplinary team across the entire perioperative continuum, pre-op, intra-op, post-op.
Let's focus on preoperative fluid management within the ERAS protocol. This changed the old NPO rules.
Significantly. The old standard was NPO for 6-8 hours, often leading to dehydration and metabolic stress before surgery even began.
What's the ERAS goal pre-op?
For the patient to arrive in the OR, truly euvolemic normal fluid volume. A Cochrane review showed allowing clear fluids up to 2 hours pre-op does not increase complications. The old 8-hour fasting rule didn't reduce gastric contents or increase pH as intended.
So the ASA guidelines were updated.
Yes, in 2017, new guidelines recommend clear liquids, 2 hours, breast milk, 4 hours, formulite meal, 6 hours, heavy meal, 8 hours, a more patient-centered, evidence-based approach.
And ERA also advises against routine mechanical bowel prep, MPP.
Correct. Miller et al. Recommended avoiding routine MBP pre-colorectal surgery to prevent dehydration. Evidence indicates MBP causes fluid shifts and increases post-operative morbidity. Avoiding it when possible is an ERAS goal.
So what are the key ERAS pre-op interventions for fluids?
2 proven methods: supplying a carbohydrate drink up to 2 hours prior and eliminating MBP when possible. The carbohydrate drink helps maintain glucose-insulin levels, reducing thirst, hunger, anxiety. Decreasing MPO time reduces dehydration, making hypotension from hypovolemia less likely intra-op. Patients are less likely to be fluid responsive after induction, indicating better starting volume status.
Now, intraoperative fluid management in ERS, how does this differ from the traditional approach?
Hugely different. Traditional intraoperative fluid management replaced perceived fasting deficits, 4:2:1, insensible third space losses, subjective 115 milli-Ka/R, and EBL 3.1 crystalloid ratio, highly subjective, variable, often excessive.
And the consequences of that traditional approach?
Cumulatively, patients receive fluid based on 4 deficit concepts. Liberal administration resulted in net weight gain. Even modest weight gain, 3 kilograms after elective colon resection, is associated with delayed gut function recovery, increased complications, prolonged hospital stay. Definitive evidence shows excessive intra-op fluid contributes to gut edema and prolonged ileus.
And optimizing fluid alone can have a huge impact.
A powerful study by Lobo et al. Determined a change in fluid management alone on the day of surgery has been shown to reduce post-operative complications by 50%. Remarkable impact.
This is where perioperative goal-directed therapy and ERA synergy comes in.
Precisely. Incorporating GDFT within ERS reduces practice variations. Instead of one provider giving a fluid bolus for hypotension and another giving vasopressors, GDFT provides a structured, evidence-based approach, improving outcomes by reducing variability.
And ERA's fluid management continues into the postoperative phase.
Yes. Early discontinuation of 5E fluids and rapid initiation of oral intake are encouraged. The traditional practice of giving liters of 5E fluid on day 1 to treat low urine output can actually cause ileus and delay discharge. ERS aims to avoid that.
This all points towards a fundamental new paradigm in perioperative fluid management.
It does. Fluid therapy in ERS is based on maintaining euvolemia. While fluid is necessary during surgery, the traditional fixed volume approach was simplistic and often excessive due to subjective factors.
ERAS also aims to mitigate the body's stress response.
Yes, mitigating the physiologic changes and avoiding fluid shifts. The body releases hormones and mediators to retain salt water, but this response causes direct and indirect cellular injury from trauma and inflammation. This combination delays healing, causes gut dysfunction, and leads to complications.
So the two fundamental elements affecting outcomes are
Fluid therapy and effective pain management, a holistic approach acknowledging the body's complex response.
All right, let's zoom back in on the microscopic yet immensely powerful players, your electrolytes. These are truly the tiny titans. We're starting with sodium balance, the master of water movement.
Absolutely. Sodium Na+ and water balance are in constant dynamic change, vital for determining intravascular volume. Sodium is the most abundant ECV electrolyte and, with chloride, responsible for most osmotic activity there.
How does it affect water movement?
Its key action is affecting ECV and ICV osmolality. Water moves across cell membranes from low to high solute concentration to achieve equilibrium. These water shifts are largely determined by sodium. ECV concentration is high, 140 MEQL, ICV low, 25 MEQL. The NAGELHOUT paste pump uses energy to maintain this gradient.
And there's a special consideration for the brain, the blood-brain barrier, BBB exception.
Yes. Unlike peripheral capillaries, the BBB has limited permeability to ionic solutes like sodium. This prevents rapid equilibration between ECV and ICV in the brain. Sodium, therefore, becomes the most important osmotically active substance influencing brain water content, making brain cells very sensitive to sodium changes.
So in treating imbalances, it's about both water and sodium.
Crucially, evaluation must consider both the solvent water volume and the solute sodium amount. Treatment can involve restricting expanding water volume and enhancing elimination supplementing sodium. Rarely just one thing.
A good example is dilutional hyponatremia during certain surgeries.
Exactly, like TURP or endometrial ablation. Absorption of large amounts of hypotonic irrigation fluid enters the ECV, diluting the sodium. The resulting hyponatremia can harm the brain and heart. There's no actual sodium loss, just dilution. Treatment involves decreasing ECV with fluid restriction or diuretics. As ECV contracts, sodium moves from interstitial back into intravascular space, normalizing concentrations.
Let's delve deeper into hyponatremia, 135 MEQL. This causes cells to swell.
It does. The intracellular environment becomes hyperosmolar relative to the ECV, leading to water influx into the ICV.
And the greatest danger is cerebral edema.
Yes, brain swelling. Because the brain is in the fixed cranium, edema is poorly tolerated. Brain cells can compensate somewhat by extruding solutes to reduce intracellular osmolality, but if this fails to match the ECF's hyposmolarity, excessive water influx leads to symptomatic edema, increased pressure, and neuronal death.
Are certain groups more at risk?
Clinical studies show menstruating women are at increased risk of brain damage from hyponatremia compared to men or postmenopausal women. Estrogen and progesterone might inhibit the NAGELHOUT paste pump needed for solute extrusion and may facilitate water movement into the brain via ADH mediation.
And hyponatremia is common.
The most common electrolyte abnormality in hospitalized patients. Hypervolemic hyponatremia in CHF or cirrhosis patients carries increased death risk. Even mild stable euvolemic hyponatremia, like from SIADH, is linked to cognitive defects and gait disturbances.
A major danger in treatment is the overcorrection risk, leading to osmotic demyelination syndrome.
Absolutely critical danger. Overly rapid correction, especially of chronic hyponatremia, 48 hours, causes severe, irreversible neurological complications. Seizures, spastic quadriparesis, coma, due to myelin damage.
What are the clinical manifestations? How do they progress?
Mild, 130 to 35 milliQL. Often asymptomatic, maybe mild neurosigns. Moderate, 125, 129. Nausea, malaise. More severe, 115, 124. Headache, lethargy, altered consciousness. Critical, 115 or rapid onset. Seizures, coma, respiratory arrest, cerebral herniation.
How is hyponatremia classified?
By serum osmolality and volume status. Isotonic hyponatremia, normal osmolality 270, 300. Often a lab artifact, pseudohyponatremia from hyperlipidemia, proteinemia, or isotonic infusions. Do not treat. Hypertonic hyponatremia, 300 millism Kyoji, caused by hyperglycemia, mannitol. Treat the underlying hypertonic state.
And the most common type?
Hypotonic hyponatremia, 270 millism Kyoji. Further divided. Hypovolemic hypotonic, lost sodium water, diuretics, GI loss, Addison's. Treat with water restriction. Hypervolemic hypotonic, excess fluid and low sodium, CHF, cirrhosis, nephrotic syndrome. Treat with sodium water restriction, possibly diuretics.
What are the general treatment guidelines for hyponatremia?
Initial management often includes fluid restriction and cautious diuresis. Newer drugs, the Vaptans, tolvaptan, condaptan, can treat hypervolemic or euvolemic hyponatremia from CMHF cirrhosis, PKD, by antagonizing vasopressin receptors, increasing free water excretion. Tolvaptan can increase sodium but hasn't shown reduced mortality.
And the key is avoiding osmotic demyelination syndrome, myelinolysis.
Paramount. Aggressive, rapid correction, especially of chronic hyponatremia, 48Hers, can lead to myelinolysis, central pontine myelinolysis, causing upper neuron disorders, quadriparesis, mental issues, death. High-risk patients include chronic cases, liver transplant recipients, alcohol abuse history.
So what's the optimal treatment strategy for correction rate?
Balance risk of edema versus myelinolysis. Correct slowly. Suggested rate, increase serum A plus by no more than 1 to 2 millinOK/EHR. Once stable, slow down to raise NA plus no more than 10-15 millimolol over 24 hours, allowing brain adaptation.
Okay, now the opposite. Hypernatremia, 145 LNQL. Cell shrink here.
Yes. Usually caused by impaired water intake. Preventing iatrogenic hypernatremia is also crucial.
Can the brain adapt?
To slow onset hypernatremia, yes, by conserving intracellular solutes to maintain volume. But rapidly occurring hypernatremia is dangerous. Rapid brain shrinking, traction on veins, risk of intracranial hemorrhage. And like hypernatremia, rapid correction of chronic hypernatremia with free water can cause cerebral edema.
How is hypernatremia classified?
By volume status, hypolimic hypernatremia, sodium causes. Diuretics, G-skin rest loss, adrenal insufficiency. Treatment, correct volume deficit with isotonic fluids first, then correct water deficit with hypotonic fluids, 0.45 puts NSD5W oral water. Isovolemic hypernatremia, water loss, causes diabetes insipidus, DI, high insensible loss. Treatment, correct water deficit, hypersonic fluids, oral water. Hypernatremia, sodium gain, water gain, causes. Excessive sodium intake, IVPO, mineralocorticoid, excess. Treatment, administered with diuretics.
What's the general correction strategy?
Replace the water deficit, calculated using formulas. Acute, 24Hers, replace relatively rapidly with hypotonic solutions. Chronic, with volume depletion. Correct volume first with isotonic crystalloids. Once stable, use hypotonic solutions for water deficit. Decrease plasma sodium by 1 to 2 millir until stable, then correct gradually over 24Hers.
What are the physiologic manifestations?
Neurologic, thirst, weakness, seizure, coma, intracranial bleeding, disorientation, hallucinations, irritability, muscle twitching, cerebral edema. Cardiovascular, tachycardia, hypovolemic, increased preload O2 consumption, hypervolemic. Respiratory, pulmonary edema, hypervolemic.
Right.
Renal, polyuria or oliguria, renal insufficiency.
And clinical signs worsen with increasing serum osmolality?
Yes. 353 agent, 7 pi millium here, very sex pili, confusion, restlessness, agitation, headache, 376, 400, ataxia, tremors, weakness, 41430, hyperreflexia, muscle twitching, spasm, 430, coma, seizures, death. Progressive cascade needs early recognition.
Are there specific sodium equations for clinical use?
Yes, crucial tools. Sodium deficit, MEQ, Na plus gold, Nes plus plasma, XTBW. Free water deficit equals Na plus 141 XTBW. Corrected sodium for hyperglycemia, cholesterol plus 0.016x, glucose 100, serum osmolality calculated 2x80 plus BUN 2.8 plus glucose 18. Fractional excretion of sodium, frexine plus, helps differentiate pre-renal 1% from intrinsic renal 2% causes. These guide precise therapy.
Next, tiny titan. Potassium balance, the heart's electrical rhythm keeper.
Indeed, potassium K plus is a principal intracellular electrolyte. 98% of the body's supply is inside cells.
And the difference between inside and outside concentration is key.
Absolutely. The difference between intracellular K plus, 150 to 160 MUL, and extracellular K plus, 3.5 to 1.0 MEQL, and the dynamic balance are largely responsible for the resting membrane potential of the cell, crucial for nerve and muscle function, especially the heart.
How is homeostasis maintained?
By absorption from the GI tract and renal excretion or reabsorption.
What controls renal regulation?
Several factors. The gradient between tubules and capillaries, distal tubular flow rate and NAS plus concentration, aldosterone concentration, and changes in pH, acidosis, alkalosis. Aldosterone is potent. Hyperkalemia triggers its release, promoting potassium excretion from renal tubules.
So disturbances affect the resting membrane potential.
Yes, symptoms of hyper and hypokalemia result from altered resting membrane potential, highlighting potassium's vital role.
Let's cover hypokalemia, 3.5 milli-UQL, the weak heart.
Defined as serum K plus less than 3.5 milli-UQL, can result from absolute deficiency, GI loss, renal loss, poor intake, intracellular shift, or increased non-renal losses. It's the most common electrolyte abnormality in clinical practice.
What causes intracellular shifts?
Redistribution from ECV to ICV can cause hypokalemia even with normal total body stores. Beta-adrenergic stimulation, insulin, and alkalosis all promote potassium movement into cells.
What are the 5 most common causes?
1. Renal losses, diuretics, drugs, steroids. 2. Increased non-renal losses, sweating, diarrhea, vomiting. 3. Decreased intake, ethanol, malnutrition. 4. Intracellular shift, hyperventilation, alkalosis, drugs. 5. Endocrinopathy, Cushing's, insulin therapy.
Is it common with diuretics?
Yes, 11 times more likely with thiazide diuretics and twice as high for men compared to women on these drugs.
What are the clinical manifestations?
Mild decrease is often well tolerated. Symptoms might include palpitations, skeletal muscle weakness, pain, below 2.5 milli-QRL, paresthesia, depressed reflexes, fasciculations, severe weakness, altered consciousness. In cardiac patients, even mild moderate hypokalemia increases arrhythmia risk, heart block, AFib, VFib, asystole.
And specific ECG abnormalities.
Yes, ST segment depression, flattened T wave, and the presence of a U wave.
How is it treated?
Depends on severity. Severe cases, hemodynamically compromising arrhythmias, aggressive IV potassium under continuous ECG monitoring. Rates up to 40-meter cases if K plus 2.0 mLAQL, but max 10-20 meter care are usually recommended to avoid iatrogenic hyperkalemia.
And less severe cases.
Once serious symptoms reversed, switch to oral supplementation. Important. Replace IV potassium with chloride. Hypochloremia hinders K plus conservation. Mix in dextrose-free solution, prevents insulin stimulation driving K plus into cells.
You mentioned a link between preoperative potassium and MAE.
Yes, long debated. Recent data. Patients with preoperative hyperkalemia 5.5 or hypokalemia 4.0 undergoing non-cardiac surgery have increased risk of MAE within 30 days. Optimizing potassium before surgery is crucial.
Now, hyperkalemia 5.0 MEQL, the arrested heart, less common.
Less common than hypokalemia if renal causes excluded. Besides impaired renal excretion, causes include high potassium intake and shifts from ICV to ECV can increase lactic acid apoptosis. Medications like digoxin, ACEIs, ARBs, blockers can increase ECV potassium.
What are some specific causes?
Pseudohyperkalemia, lab artifact, hemolysis, etc. Increased intake absorption. Supplements, diet, salt substitutes, stored blood, K plus NACI-containing meds. Impaired renal excretion, renal failure, tubular defects, transplant issues, K plus NOx-sparing diuretics, hypoaldosteronism, Addison's, drug-induced, transcellular shifts, acidosis, hypertonicity, insulin deficiency, drugs, brew blockers, digitalis tox, sexanolcholine, exercise, periodic paralysis, cellular injury, rhabdomyolysis, hemolysis, tumor lysis, burns, crush injuries.
And the cardiac impact is severe.
Dramatic, especially if it occurs rapidly due to K plus's role in repolarization, can stop the heart.
What are the progressive ECG changes?
5.5, 6.5 milliQL, peak T wave, 6.5, 7.5, P wave flattening disappearance, PR prolongation, 7.0, 8.0 QRS prolongation, 8.5 QRS degrades to sine wave pattern, VFib, cardiac arrest, vital warning signs.
How is it treated?
First, exclude pseudohyperkalemia. Strategy involves three things. 1, stabilize cardiac membrane. 2, drive K plus from ECV to ICV. 3, remove K plus from body. Chronic cases, e.g. renal failure. Oral K plus binder like powder rumor.
What about acute severe cases based on ECG?
Pending arrest, loss of P wave, wide QRS, immediate therapy. 1, IV calcium. 10 millirel, 10% KCl over 10 mililin, or 10 millirel, 10% key gluconate over 3-5 minutes. Onset 1-3 minutes. Stabilizes membrane. 2, IV sodium bicarbonate, 50-100 milliQ over 10-20 minutes. Onset 5-10 minutes. Shifts K plus intracellularly.
What if there are just peaked T waves?
Potassium effect. Peak T waves. Prompt therapy needed. 1, glucose insulin infusion. 50 milliliter D50W plus 5 units. Regular insulin IV. Monitor glucose. Onset 30 minutes. Shifts K plus intracellularly. 1, glucose insulin infusion. 2, immediate hemodialysis.
And if there are no ECG changes, just high levels?
Biochemical evidence only.
Yeah.
Effective therapy needed within hours.
Yeah.
1, potassium binding resins, GI tract onset 1-2 HR, GI excretion. 2, promote renal excretion.
Yeah.
Calcium adivaloncation. 99% is in bones. Hydroxyapatite. The remaining 1% is in plasma and cells. Vital for bone structure, but maybe most important is its role as a second messenger, coupling receptors to responses.
Like muscle contraction and hormone release.
Exactly. Critical for muscle contractions, release of hormones neurotransmitters, also important in blood coagulation and myocardial contractility.
How does it exist in the ECV?
A small percentage is exchangeable with ECV, found in 3 fractions. Ionized calcium, 50% physiologically active, most clinically significant. Bound to anions, 10%. Bound to plasma proteins, mainly albumin, 40%.
Does pH affect this?
Yes. Acidemia at lower pH decreases protein binding, increasing the ionized fraction.
How is it measured? Normal levels.
Total serum calcium, normally 9.0 to 10.5 milli-GDL, but total levels depend heavily on albumin. Direct measurement of ionized calcium is preferred, especially in critically ill.
And how is it regulated?
Primarily by release inhibition of parathyroid hormone, PTH, but also vitamin D and calcitonin. PTH levels adjust to hypercalcemia, triggering events to normalize levels.
Let's cover hypocalcemia, 8.5 milligdl total, ionized 4.0 milligdl, the twitching nerve. What causes it?
Diverse causes. PTH insufficiency, primary secondary neck surgery, hypomagnesemia, vitamin D insufficiency, rickets, malnutrition, liver renal disease, other sepsis, anticonvulsants, PTH resistance, calcium chelation, hyperphosphatemia, citrate alkalosis.
What are common intraoperative causes?
Most likely hyperventilation and massive rapid transfusion. Hyperventilation causes alkalosis, increasing protein binding, decreasing ionized calcium. Massive transfusion involves citrate, which chelates binds calcium, decreasing available calcium.
What are the clinical features?
Neuromuscular, paresthesias, weakness, spasm, tetany, Shostak-Trousseau, signs positive. Hyperreflexia, seizures. Cardiovascular, bradycardia, angina, hypotension, CHF, arrest, digitalis insensitivity, QT prolongation. Pulmonary, bronchospasm, laryngospasm, psychiatric, anxiety, depression, confusion, psychosis.
How is acute hypocalcemia treated?
Infusion of calcium salts. Calcium chloride is most bioavailable. 272 mg elemental K 10 mol, fastest correction, but high risk of venous irritation necrosis. Use central line if possible. Calcium gluconate, 93 mg elemental K 10 mol, is safer peripherally. Regimen, 10 mol, 10% K gluconate over 10 ml, and then infusion, 0.32 millisieverol elemental K. Correction guided by ionized calcium levels.
Now, hypercalcemia, 10.5 milligdl total, ionized 5.6 milligdl. The lethargic body, what causes this?
Typically results from calcium movement from bone to ECV exceeding renal excretion.
Right.
Primary hyperparathyroidism, 50% cases. Malignancy, second most common, are main causes.
Other causes.
Medications, thiazide, lithium, vit-DA toxicity, granulomatous disorders, sarcoidosis, PB, non-parathyroid endocrine disorders, hyperthyroidism, adrenal insufficiency, miscellaneous, milk alkali syndrome, immobilization.
What are the clinical features? Stones, bones, groans, psychiatric overtones?
That's a classic mnemonic. Neurologic, fatigue, weakness, confusion, lethargy, seizures, coma, hypotonia, cardiovascular, hypertension, ST elevation, bradycardia arrest, AV block, short QT interval, potentiates digoxin toxicity, renal, polyuria, polydipsia, dehydration, nephrolithiasis, stones, GI nausea, vomiting, anorexia, peptic ulcer, pancreatitis, constipation, Crohn's.
How is it treated?
Volume expansion with 0.9% NS increases renal excretion. Loop diuretics further enhance excretion. Other agents: bisphosphonates, mithromycin, calcitonin, glucocorticoids, phosphate salts. Acute severe cases with life-threatening arrhythmias. Hemodialysis rapidly lowers calcium.
Second to last, titan. Magnesium balance, the enzyme cofactor, and muscle regulator.
Right. Magnesium, the second most abundant intracellular contagion after potassium.
Yep.
40-60% stored in muscle bone, 30% in cells, only 1% in serum. Regulated by intestines and kidneys.
What's its physiological importance?
Cofactor in numerous enzymatic reactions: energy metabolism, protein synthesis, neuromuscular excitability, and function of the NAGELHOUT pace pump. Chronic hypomagnesemia increases cardiovascular death risk. Therapeutically, IV magnesium can relieve severe bronchospasm, decrease post-op pain, normal plasma level, 1.53.0 mmQL.
Let's look at hypomagnesemia, 1.5 mmQL. The arrhythmic muscle, common.
Common in hospitalized patients, especially critically ill. Causes: increased renal GI loss, poor intake, medications.
What are key causes?
Excessive alcohol intake, major. Pregnancy, renal losses, renal failure, diuretics. GI losses, diarrhea, angiossuction, pancreatitis, endocrine, diabetes, hypothyroidism. Medications: imidoglycosides, amphotericin, beta agonists, cisplatin, cyclosporine, diuretics, PPIs. Congenital disorders.
What's the physiologic impact?
Inhibitory effect on NAGELHOUT pace pump, decreasing intracellular potassium, alters cardiac resting membrane potential, phase 4.
What are the ECG changes?
Flat T waves, U waves, prolonged QT interval, widened QRS, atrial ventricular arrhythmias, including torsades de pointes.
You mentioned alcohol use as a big factor.
Yes, 30% of patients with excessive alcohol use admitted have hypomagnesemia, poor diet, diuretic effect. Severe cases treated with IV magnesium sulfate, 1-2 game over 5 minutes, monitored the 1-2 air infusion.
And hypermagnesemia, 3 MEQL. The depressed reflexes, usually iatrogenic.
Most commonly iatrogenic, for example, the admin. Can result from treating preeclampsia, preterm labor, ischemic heart disease, arrhythmias.
What are the clinical manifestations?
Depression of peripheral central nervous system, hypotension, QRS widening, PRQT prolongation, heart block, cardiac arrest. Symptoms depend on rapidity and degree of increase.
Specific levels matter.
Yes. 4 or 5 milligdl. Decreased deep tendon reflexes.
Right.
5-7. Hypotension. 10. Respiratory paralysis. Coma. 10-15. Heart block. 10-24. Cardiac arrest.
And drug interactions.
Magnesium potentiates non-depolarizing neuromuscular laxants. Use carefully monitored. treatment, discontinue magnesium. Urgent situations, bradycardia, heart block, related depression.
Yeah.
Use calcium chloride as antagonist.
Our very last tiny titan, phosphate balance, the energy buffer.
Phosphate. Majority in bone, 85%. Small amount in plasma. Phospholipids, esters. Inorganic phosphate, the ionized form. Intracellular phosphate, crucial. Part of ATP, energy currency. 2,3-DG regulates O2 release from HB. Acts as acid-base buffer.
How does it relate to calcium?
Concentration in plasma inversely proportional to calcium. Tightly controlled by same mechanisms. PDH, vitamin D, calcitonin.
Let's cover hypophosphatemia, 2.0 milli-GDL, oxygen starvation. What causes it?
Most likely increased renal excretion, intestinal malabsorption, cerebral alkalosis, accelerated ATP use. Other causes, MGL antacids, chronic alcohol misuse, hyperparathyroidism.
What's the key physiologic impact?
Decreased 2003-DPG in red blood cells. Causes leftward shift of oxyhemoglobin dissociation curve, increased HB affinity for O2, decreased oxygen unloading to tissues.
What are the consequences?
Decreased O2 delivery, anaerobic metabolism, decreased ATP acidosis, consequences of low ATP, hypoxia, heart block, bradycardia, asystole. Manifestations relate to poor O2 transport ATP, altered nerve muscle function, platelet dysfunction, confusion, coma, seizures, weakness, respiratory failure, cardiomyopathy.
Finally, hyperphosphatemia, 4.7 milli-GDL. Calcium problems. What causes this?
Majority of phosphate is intracellular. Cellular destruction, metastatic disease is a leading cause. Other causes, acute and chronic renal failure, tumor treatment, phosphate laxative enema use, hypoparathyroidism.
What's the main physiologic impact?
Increased phosphate levels can produce clinically significant hypocalcemia as calcium phosphate deposit in bone.
So symptoms are like hypocalcemia?
Yes, signs symptoms often synonymous with hypocalcemia, muscle twitching, cardiac issues. Treatment, aluminum hydroxide antacids, binds phosphate in GI tract. Dialysis for severely elevated levels.
We've now navigated the intricate currents of your body's fluid distribution, meticulously explored the complex dynamics of intravenous fluids, weighing the long-standing debates between crystalloids and colloids.
Quite a journey.
And truly witnessed how the profound stress of surgery can ripple through every single system. We've also shown a powerful spotlight on the vital, sometimes volatile roles of your tiny titans, the electrolytes.
What stands out here, and is truly a core takeaway, is how deeply interconnected all these systems are. From the micro-level dance of Starling forces and the protective glycolytics to the macro-level impact of a major surgical procedure.
Right.
Every single decision in fluid and electrolyte management has profound cascading effects on patient outcomes. This deep dive wasn't just about understanding what is happening at a superficial level, but truly grasping why it matters so profoundly for health and the journey to recovery.
And that's exactly where the mastery comes in, isn't it? As updated scientific information continuously refutes commonly accepted beliefs about fluid administration, it's abundantly clear that continuous modification and evolution of clinical practice are absolutely essential for achieving optimal patient outcomes.
Yeah, you can't stand still.
Goal-directed fluid therapy allows for that measured, real-time, and individualized approach, preserving vital organ perfusion and minimizing the potential for harm that comes from either too little or too much fluid.
Precisely. And for you, the listener, the knowledge that inappropriate fluid administration, whether it's under resuscitation or over resuscitation, carries significant and tangible risks, from severe organ complications and impaired healing to even increased mortality, highlights why this seemingly niche topic is so fundamental to modern healthcare, and why a thorough, nuanced knowledge of electrolyte disorders, understanding their physiological effects, characteristic signs, symptoms, and appropriate treatments, is truly essential for competent and excellent clinical practice.
So if our bodies are these incredibly complex, self-regulating internal oceans, always striving for equilibrium, and if modern technology now allows us to monitor these physiological variables with ever greater precision, the real challenge moves beyond just crunching the data. The profound question for us, and for the future of healthcare, becomes, is the ultimate goal of fluid management simply about achieving perfect numbers on a monitor, or is it also about truly understanding and respecting the unique, complex resilience and often fragility of each individual patient? What aspects of your own health, now equipped with this deeper understanding of your body's hidden fluid dynamics, might benefit from this newfound knowledge?